Assalamu alaikum. Good morning, all of you.
Good morning.
Good morning.
Sir. A warm welcome from the wholeheartedly welcome from the organizing secretaries. Both organizing secretaries are here. Myself and Professor Dr. Aga Parvez Masih is also here. Parvez sir, are you here?
प्लीज मुझे वो स्क्रीन शेयर करने का अलाउ कर दो.
Yes sir, sure sir. पहले आपका इंट्रोडक्शन तो कर दें सर सबसे.
नहीं, असल में फिर वो देर लगती है फिर उसमें करने में.
Just doing that. Making you the co-host sir in a moment. सर आपको को-होस्ट बना दिया है. A very warm welcome to all the respected dignitaries, our participants. We welcome you to the second day of the International Conference on the Healthcare and Wellbeing, Current Trends and Challenges. As you all aware of that post-COVID era, all these issues, psychosocial issues, medical issues, health concerns, this is a very pertinent topic for the discussion on how to manage our health and how to promote the overall well-being in ourselves, in our societies, as well as in our community as well. So with this approach, we tried and we pondered overall and we deliberated and we came up with this topic. And fortunately, we got more than 13 confirmed speakers from India as well as abroad, including United States of America, United Kingdom, speaker from Sweden, even Dr. Leila from Texas, United States is here, part of the conference. And today's lecture, the first inaugural lecture of the second day, our invited guest of honor, Professor Abbas Ali Mehdi sir is here with us. So with a brief discussion, brief intro of sir, I'll hand over the mic to sir for his deliberation. Talking about sir's contribution to the field and his continuous support to organizations like us has been a pillar of strength for us. Sir is currently positioned as a professor and head department of biochemistry, King George Medical University, Lucknow. He has also served as the vice chancellor of ERA University for a brief period of time. Sir has more than 3 decades of research and teaching experience with more than 350 research publications having over 5,000 citations. He has more than 25 book chapters to his credit. Sir is also a member of the editorial boards of various reputed national and international journals and magazines. Talking about Sir's outstanding academic and research contributions, so he has made pioneering contributions in the area of natural products, metal toxic, and free radical biology. His seminal work on protection from free radical mediated cellular injury by herbals in diabetic rats is also well recognized in the academic and scientific fraternity. Sir has also extensively studied on possible association of aluminium with Alzheimer's disease, which have demonstrated that aluminium may be linked with lipophysiogenesis, mitochondrial, and endoplasmic reticulum stress, and these changes may be responsible for the development of age-related disorders such as Alzheimer's disease, one of the very pioneering research as well. Sir is also the president of Indian Society for Lead Awareness and Research and has also served as the vice president of Society of Free Radical Research. Sir is also the former president of the Indian Academy of Biomedical Sciences, and he is also on board as visiting professors on various international universities as well. Without wasting much of time, I would request my colleague, Dr. Agha Parvez Masih, to welcome Sir with his kind words.
Good morning to all participants and dignitaries and esteemed guest lecturers. It is a matter of great honor for us that Professor Abbas Ali Mehndi always spare his valuable time for our conference, and we feel privileged by his presence. And there is no doubt he is known for his extraordinary work on lead toxicity and various scientific aspects. And all the participants, I hope all the participants will gain much from his knowledge. And on the behalf of all organizing committee and the participant, I heartily welcome Professor Abbas Ali Mehndi. And I will request Abbas Ali Mehndi, sir, to please start the lecture.
Thank you, Dr. Masih. It's always a pleasure. First of all, my compliments to both of you for organizing this third international webinar. And of course, due to this COVID times, we have to have this web platform to organize the meetings. And of course, that fellowship which is there while we are together physically is not there, but still it's a great platform, and not many people I'm seeing that from India and abroad have joined this meeting. So compliments to you all for organizing this wonderful meeting, and I'm sure that this will be beneficial for the participants in the long run. Today I'll be speaking on the stress management. Although this is not my field, I'm basically a biochemist, and stress we all go through is a body response to the interference in the normal physiological equilibrium. And there are a lot many stressors, whether they are the, first of all, I'll talk about the stressors which we face in our daily life, which is not only the psychological or emotional stress, but I'm talking about the physical stressors because body is exposed to it. And there are a lot many physical stressors like radiations are there, UV light is there, and lot many variations in temperature, humidity, and all that is there. So body is exposed to it. Similarly, there are chemical stressors also, like not many chemicals, xenobiotics are there, to which we are exposed to. And then biological stressors, like for example, bacteria, viruses, and we are going through that phenomena also. But today I'll be mainly concerned with and talking about the mental or emotional strain or tension which we go through, and especially during trying times. So I'll be concentrating more on that. But being a biochemist, I talk about all the stressors, whether they are the chemical stressors or physical stressors or the biological stressors or the emotional or psychological stress. So can we manage this stress? Both it is yes as well as a no, because it depends upon ourselves that how to cope up with the stressful conditions. Now, stress is not per se in our environment as such, but it is what we perceive in our mind and body. So that is the emotional stress, that something may be stressful to a particular person that may not be that much because stressful to another one, because it is the body's response or the personal response or the emotional response depends upon how you perceive a situation or circumstances in which we are there. Now, the stressful feelings are, which we all go through, is worry, being tense, tired, frightened, depressed, anxious, or we are angry about something. So all these things together, they or individually, they cause, they lead to the stressful conditions. And the types of stressors, that is the emotional or psychological stresses, may be the physical environment or the social interactions or the organization in which we are there, or the major life events like, for example, some disturbance in the family or some trauma due to some death, or daily hassles also. They are the external factors which may lead to a person to be under emotional or psychological stress. Similarly, there are internal factors also, like lifestyle choices, negative self-talk, or mind traps, or personality traits, which is individualistic, that individuals go through that. Similarly, there are physical environmental factors which may also lead to psychological stress. This is noise, bright light, especially in the night, heat or cold, and confined to the spaces that again may lead to the claustrophobia, may lead to some people are some people are prone to be claustrophobic. That all may lead to, these are the physical factors which may lead to emotional stress or emotional trauma. Similarly, in social interactions like bossism, aggressive behaviors by the others, bullying by the others, or rude behavior by your seniors or by juniors. So these social interactions may also lead to the person who may not be able to respond or to cope up with it. That leads to emotional or psychological stress. Similarly, if you are working in an organization, in a system, and there are stringent rules and regulations, and there is red tapeism, or there are deadlines, fixed deadlines to cope up with it, that all leads to emotional trauma, and that all leads to emotional stress. Similarly, I talked about it, that major life events, like, for example, especially for the females, emotional trauma is there after birth. Similarly, death of a close one, loss of a job, or sometimes promotional avenues are not there, or marital status change, divorce is there, or some problems, interpersonal relationships problems are there. So these are the major life events which may lead to emotional or psychological stress. Similarly, daily hassles like commuting, the traffic congestion and all that, you have to rush to a place and you are facing the traffic. So this commuting may also lead to stress. Similarly, not many people, they misplace the keys and they have to rush to the office and they are not finding the key of the vehicle. Then also you are under stress. Similarly, if your car or your vehicle is broken down and you have to be there somewhere on time, that also lead to, these are the daily hassles which may lead to a person under stress. Similarly, there are internal stressors also, like lifestyle choices. Some people are prone to, like, for example, they talk negative always. So that's a mindset that they always perceive the things in a negative way. Similarly, mind traps are there, or personality traits are there. So that lead to the person to be prone to be more under stress. So these are the internal lifestyle choices, like, for example, lack of sleep. These days, because of the social media and all that, people chat for a long time, or they are involved in the social media, Facebook and WhatsApp and all that. So in the night, and they don't get proper sleep. Similarly, excessive use of caffeine also lead to deprivation of sleep. And work overload, of course, is another can be another reason for your work schedule is such that you are unable to cope up with your life in a proper manner. So some people are basically pessimistic. They self-criticize or overanalyze the things. So that negative things negativity always leads, I always say that negativity always leads to negative feelings and negativity all around. So this negative self also is a major problem for certain people, to be always under stress. Then mind traps, that unrealistic expectations. They expect a lot from their own selves and from others also. And they think, some people are like that, that they take things personally, all or nothing thinking, that we must get everything. And rigid thinking, people are rigid. So these traits, these mind traps leads to stress. Personality traits also leads to stress. Like, for example, some people are extremely perfectionist. They want perfection everywhere, which is not possible, always not possible. And some workaholics, like they enjoy work and they like work, that's fine. But if they are workaholics all the time, they are working, then they neglect certain things, and that leads to stress. So stress in itself can neither be negative or positive. It is our, as I said earlier, that it is our perception of that stimulus which determines whether a situation is stressful or not stressful. And some events that is exciting and pleasurable to one person, as I said earlier also, can be painful or stressful to another. And stress can be both negative and positive. If it is contributing factors to, for example, negative stress is responsible for conditions like headache, digestive problems, lot many physical problems like skin insomnia, ulcers. Excessive stress leads to excessive secretion of gastric juices, and gastric secretions are increased, and that leads to ulcers, gastric ulcers. And excessive, prolonged, and unrealistic stress can have harmful effect on both physical, mental, as well as spiritual health. But there can be also a positive stress, which can be a motivation, which can provide you a stimulus to face the challenging situations. So stress, if you perceive it in a negative manner, then it is harmful, both physically, mentally. And if you take it in a positive manner, then you can be alert and you can face the situation, you face your life in a positive manner. And sometimes under certain conditions, stress is even important and useful to cope up with certain situations in the life. But as I said, it is the how to react or how to cope up with stress depends on each individual, and everyone is different with unique perceptions and reactions to events. And there is no single level of stress for any particular person. It is how you perceive the things. Some are more sensitive owing to experience in, for example, in childhood, and some because of certain reasons, like, for example, religion or teachings by teachers and family background, that people perceive certain situations in a different manner. So it is basically, stress is basically individualistic, how an individual perceive it and how he or she reacts to it. Most of the emotional and psychological stress is self-generated. That is how we perceive life, whether an event make us feel threatened or stimulated, encouraged or discouraged, happy or sad, depends to a large extent on how we perceive ourselves. I have been repeating it again and again, that it is our perception which leads to our response to a particular situation or particular circumstances. Self-generated stress is something which is really a paradox, because so many people think that external causes are responsible when we are upset. But recognizing that we create most of our own upset is an important first step towards coping up with that. Because if you can recognize the source of your stressor, then you can cope up with it. And as I said earlier, that basically our endocrine system is responsible to respond to the stress, and demands on the physical or mental situations of the body results in the secretion of the hormones like adrenaline or testosterone, and that leads to the changes in the biochemistry of the body. And endocrine responses leads to, for example, increased pupil dilation, perspiration, increased heart rate or blood pressure because of the hormone secretions, rapid breathing, muscle tenderness, increased mental alertness. So this all is basically the endocrine response to the stress. Our system response whenever we are under stress, that is the fight and flight hormone are secreted, and that leads to our body responding in a different way. Now, as far as the symptoms are of the stress, maybe physical, maybe mental, maybe behavioral, maybe emotional, all these symptoms may be there. And the physical symptoms are that our sleep patterns may change. Sometimes there may be sweating, there may be tingling in the hand and feet, there may be breathlessness. So these are the physical symptoms, that palpitations may be there, fatigue. If you are unable to sleep properly in the night, then next day you gain the fatigue. Moreover, if it is chronic, then it leads to digestive changes, headaches, and pains. Moreover, if you are continuously under stress, then your immunity is compromised, then you are more prone to infections, and the stress leads to lot many changes in our body homeostasis, and that leads to a person getting prone to certain infections. And moreover, as digestive system is involved, then indigestion and other problems leading to even, like, for example, ulcerations in the stomach may occur. Now, as far as mental symptoms are concerned, lack of concentration, memory lapses, difficulty in decision making, confusion, disorientation, and even panic attacks. And that is very common in adolescents and younger people, that if they are unable to cope up with, then panic attacks occur, and they can't concentrate on the things. So these are the mental symptoms. Now, as far as behavioral symptoms are concerned, there may be appetite changes, eating disorders. Some people, they eat more. Some people respond in a way that they eat less. Then if those who are chronic abusers, like, for example, increased intake of alcohol may be there, or even somebody may depend on drugs and all that. Increased smoking may be there, restlessness may be there. So these are, or how you perceive that you are, sometimes you start thinking that you are suffering from a chronic ailment, hypochondria may be there, that is, you are having a cancer or some other disorder. So these are the behavioral symptoms which may occur. Emotional symptoms are depression, impatience, and sometimes you like to cry more. And moreover, if it is it perpetuates, then a deterioration of the personal hygiene and even appearance. You forget about maintaining personal hygiene, and you are unconcerned about your appearance. So that are the emotional symptoms which are of chronic stress. And lot many stress. I always say that stress leads to distress, and most of the diseases are because stress related. Because whenever you are in stress, and especially chronic stress, it leads to ill health, and whether it is cardiovascular diseases or neurological dysfunctions, asthma, diabetes, all that, or neurodegenerative diseases or arthritis, that all is because we don't know what's the cause of it. But stress, certainly, whether it is physical stress, emotional stress, psychological stress, or chemical stress, biological stress, that may lead to illnesses like cardiovascular diseases, diabetes, asthma, immunological dysfunctions, autoimmune diseases, all that. Digestive disorders, premenstrual syndrome, PMS is very common in ladies, depression, and that is a big problem that lot many people suffer from depression these days, and we need counseling, we need psychological support for every individual nowadays, because of excessive stress which we all face due to change in the lifestyles and all that. Now, as a biochemical person, I'll always say that whenever you are under stress, then your antioxidant and oxidant levels, they changes in the body. And if they are normal, under normal conditions, we have got in our body normal levels of toxic chemicals like free radicals, and we have got sufficient antioxidants in the healthy cells in a normal circle. And whenever there is stress, whichever type of stress it may be there, whether it is chemical stress, biological stress, emotional stress, or physical stress, that leads to the excessive secretions of excessive generation of free radicals from the stressful condition. And that leads to, if your body is not well coped to face with it, then your antioxidant levels decreases, and body responds to a stressful state. And this shows that whatever the factors are there, whether the chemicals or whether they're the biological stressors or whether they are the emotional stressors, they all leads to oxidative stress. And oxidative stress is the reactive oxygen species which are generated in our body, in a normal condition also. But if they are generated in excess because of the stressful conditions, they lead to almost every disease, whether it is cancer, asthma, COPD, diabetes, arthritis, infertility, whatever the disease you say, it is related to stress. Now, as far as the cost of stress is concerned, as I have been emphasizing, that 80% of all the modern diseases have their origin to the stress. And in India, it is estimated that 40 million working days per year are lost directly from the stress-related illnesses. And billions of dollars, billions of rupees are lost because of this problem. And stress at work has a great potential, because good relationships with colleagues are crucial, and discussions, positive relationships play a very important role to cope up with the psychological or physical or behavioral problems which we face in any organizational setup. So the social interactions play a very important role. And as far as control of stress is concerned, I think the ABC strategy is important. That is awareness, a balance of everything, and control. So these three things play a very pivotal role, that we must be aware of the situations in which we are, and we must keep a balance and control the things which are going out of control. That if our response is more to a certain situation or certain circumstances, then we must control that. So this ABC strategy, that is awareness, a balance of everything. And in biochemistry, I'll always say that a balance is very important, because excess of anything is harmful, because body can cope up, the body homeostasis can cope up to a certain level of anything, because we have got an inherent capacity and capability to fight with the stress to a certain level. But beyond that, we succumb, and if we succumb, then we are prone to diseases. And stress management techniques basically are being the various psychologists and people who are here, they must be knowing that change in thinking is very important, change in behavior is very important, change in lifestyle is very important. These techniques must be implied, that if your thinking is negative, then you must talk to people, interact with people, and convert your thinkings to a positive thing. And similarly, the behavior and lifestyle has to be changed to manage the stress. We can't eliminate the stress, and but basically it is that our goal should not be to eliminate it, but how to cope up with it, how to live with it, and let us control everything so as to understand it in a better manner, and that's how we can at least cope up with the stressful states. And don't take things in a very negative way, and always think that this time will also pass. If you are under a stressful condition, in a negative situation, in a negative circumstances, then this motto should be there, that this too shall pass. And moreover, our goal should be that we must act before and don't react to the things, because when people react to the things, then it leads to emotional disturbances, and we must plan ahead and always have a ready plan B or plan C and plan D, as we call it, because if one fails, then at least the other, and that's what we need to teach our children, that they must be ready with a plan B, that if plan A fails, then at least we can do in the life with a plan B. Poor organization is one of the most common causes of the stress, and structural approaches are very important to manage and achieve our goals. And basically, it is our personal management, time management, and our personal management of the organization in which we are working, that is very important, to have a structural approach and to manage stress. And the ultimate in the stress management do's and don'ts are that first and foremost, it is never to overindulge in anything. That is very important and vital. I think that's what is the take-home message, that first and foremost, never overindulge anything, and strive to do as well as you can, but do not try to be perfect, because if you try always to be perfect and somewhere you fail, then you will be under stress. And autogenic relaxation through regulated breathing or pranayama will can help and to manage stress. And social interactions and speaking to others, talking to others, confiding with others, that is another an important aspect of managing stress. And interacting with people in a positive manner, talking with people in a positive manner, and life in general, living life in general in a positive manner, that is very important to manage stress. Because if you perceive things, if you talk about things, always negative things, then you will be always under stress. So that's what my mantra, that never overindulge in anything, and do the best you can. Try to do the best you can, but don't try to always be perfect in everything. So that's what my take-home message is. And thank you very much for listening to me. And I hope that I have not taken much time, and I have completed my talk within time. So thank you very much.
Thank you very much, sir. Indeed, it was a very enriching session. And no, sir, your lecture was way beyond within your stipulated time limit. And I hope I am audible.
Yes,
Yes,
yes, you are able.
Yes.
Sajid, I will take 1 minute only.
Sure, sir. Sure.
अब्बास भाई बहुत बहुत अच्छा, बहुत इंफॉर्मेटिव लेक्चर था। और आज हमने एक लोगों ने एक चीज ये सूची दिखी है, जो ऑब्जर्व करी है, कि कोरोना के बाद में जो फेसेस आए हैं, उसके अंदर बहुत ज्यादा इमोशनल स्ट्रेस भी है, ऑफिस का स्ट्रेस भी है। और उन सब चीजों को, हालात को देखते हुए ये जो स्ट्रेस मैनेजमेंट का आपका लेक्चर है, ये बहुत रिलेवेंट है और बहुत ही यूजफुल इसके अंदर जो थे आपने टिप्स दी हैं। अगर आदमी
देखो सज्जाद, ये लोग एक्सपर्ट हैं इसके, मैं तो नहीं एक्सपर्ट हूं, बट आई ट्राई टू गिव यू अ ब्रीफ ओवरव्यू दैट हाउ टू, बिकॉज़ आई एम
ये तो आपकी हम्बलनेस है कि आप नहीं कर रहे, लेकिन बहुत इंफॉर्मेटिव, बहुत ही अच्छा और बहुत अच्छी टिप्स हैं। और हमें पूरी उम्मीद है कि जितने भी पार्टिसिपेंट्स हैं, इससे जो है उनको काफी फायदा उठाएंगे। एक बार फिर बहुत बहुत शुक्रिया प्रोफेसर अब्बास।
थैंक यू।
Sir, audience may say there are few questions. If you,
sure.
Sir, we have Dr. Hina Nishat, and she wants to put up some question, but she hasn't put up the question. Dr. Hina, if you are there, if you are listening, you can put up the question.
Yes, I am there. Sir, Assalamu alaikum. Very nice, sir. Very nice deliberations, sir. और मुझे लगता है कि सर आज के टाइम में तो हम सब लोगों को इन सब चीजों को, जो भी आपने बताया, इसको जरूर अप्लाई करना चाहिए सर। बट मेरा ये क्वेश्चन है कि जैसे हम लोग जिस एज में हैं, वो हम लोग के लिए इजी है, जो भी चीजें मैनेज कर सकते हैं। स्ट्रेस तो है ऑब्वियसली सब, लेकिन ओल्ड एज में अगर ये प्रॉब्लम हो रही है सर, जैसे मेरी मदर है, उनके साथ बहुत ज्यादा, मतलब शी इज वेरी परफेक्ट फाइन, उनको कोई प्रॉब्लम नहीं, हेल्थ इशू नहीं, बस लेकिन उनको स्ट्रेस बहुत है, मतलब वो छोटी छोटी चीजों का स्ट्रेस ले लेती हैं, और उसको कैसे हम मैनेज करें। मैं काउंसलिंग भी खुद करती हूँ सर।
बेटा देखो, उसमें आई थिंक मेनली इट इज बात करने से होता है, और थोड़ा सा क्या कहते हैं, ओल्ड एज में भी हो जाता है ना कि इतना टाइम लोग नहीं दे पाते हैं लोग। अब हम लोग भी सब बिजी हो गए, तो वो फिर आदमी अकेला रहता है तो परसीव चीजों को दूसरी तरह से करने लगता है। तो आई थिंक इफ यू इंटरेक्ट मोर एंड आस्क हर टू गेट हरसेल्फ इन्वॉल्व्ड, वेदर इफ यू लाइक कुकिंग और निटिंग और स्टिचिंग, व्हाटएवर थिंग जिसमें कुछ अचीव कर सके, तो वो एक होता है कि कोई उनसे कहो कि मम्मी कोई खाना अच्छा बनाइए, आज हम ये खाएंगे, एंड व्हेन शी कुक्स एंड यू कम बैक एंड यू ईट, तो उसकी तारीफ करो, जैसा बहुत अच्छा आपने बनाया था, मजा आ गया आज खा के। जी। आपको लगता है कि एक यूजफुलनेस है हमारी। तो ओल्ड एज में बेसिकली हो जाता है कि पीपल आर अलोन एंड they don't go out and they don't interact with a lot if that type of personalities. तो आई थिंक मैं तो अपनी मदर के साथ में यही करता था, मदर मेरी नहीं है, उनसे मैं यही कहता था कि वो आप बहुत अच्छा बनाती थी, आप बनाइए, वो आके भी बात करते तो शी यूज्ड टू फील वेरी हैप्पी। तो आई
हाँ
थिंक
जी
जो चीज भी वो करें घर में, कोई चीज अगर नहीं बनाए या कोई चीज सिलाई करें या बुनाई करें, जो भी करें जो
जी जी
जिसको उनको अच्छा लगता है, तो आई
जी
थिंक
जी
give her a task and appreciate that task when she do, then she will get
श्योर
into
सर
it and she will
जी
enjoy it.
जी 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 थैंक यू सो मच सर, मैं आज ही से करूंगी इंशाल्लाह।
बिल्कुल बिल्कुल बिल्कुल
जी
बिल्कुल।
जी
जो डिश
शुक्रिया
अच्छी
सर।
बनाती हो कह लो इससे अच्छी तो डिश मैंने खाई नहीं आज तक, तो she will
जी
feel
जी
happy and she will try to do more.
जी 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 सर, शुक्रिया सर, थैंक यू सर।
Any more questions from the audience? Anything to ask, to discuss? Okay, sir, I don't think we have any other
ठीक है।
question.
अच्छा यार, एक हम लीव कर सकते हैं या अभी अभी तुम्हारा कोई लेक्चर है इसके बाद में प्रोग्राम?
Yes, sir. After you, we have the scheduled lecture by Professor Rakesh Kumar
Okay.
Tripathi.
Okay,
Geriatric-
okay, Rakesh, Professor Rakesh का है. So I'll
Yes.
listen to it. I'm here.
Sure, sir. Most welcome, sir.
Okay, okay.
Sir, humble request that please आप अपनी unshare कर लें slide.
ये इसको शेयर कर। ये ये शेयर हो क्यों नहीं रहा है? अच्छा, मैं आउट होता हूँ फिर शायद हो जाएगा। हो गया ना?
Yes, sir. It is done now. So after this enlightening session by Professor Abbas Ali Mehdi, sir, next scheduled lecture is by Professor Dr. Rakesh Kumar Tripathi, Department of Geriatric Mental Health, King George Medical University, Lucknow. Tripathi, sir, I hope you are in the meeting.
Yes, Dr. Sajid, I am here.
Yes, sir. Sir, I am giving you the permission to share. I have made you the co-host as well.
Thank you.
A brief introduction of our esteemed speaker. Professor Dr. Rakesh Kumar Tripathi is serving as in the Department of Geriatric Mental Health, King George Medical University. Sir is also the member of Indian Association of Clinical Psychologists, member of Rehabilitation Council of India. Sir is also the life member of Association of Industrial Psychiatry of India, along with the Indian Association for Geriatric Mental Health. Sir has been associated with KGMU for more than 10-12 years, imparting services in the Department of Geriatric Mental Health. Sir has a keen research interest in the areas of cognitive psychology, neuropsychology, community mental health, as well as rehabilitation, and has been giving time towards the intervention and management planning for the geriatric population. With this brief introduction, sir, I would like to invite you for your deliberations.
Thank you very much, Dr. Sajid. You have given me opportunity to share my thought in the third international conference organized by the IMHRC, Indian Mental Health and Research Center, UP India, National Institute of Higher Education, and CRPG College, Lucknow. The topic which was assigned to me is the community mental health and well-being in India. So this is the topic which I have planned, and here we are two communities, teacher and students. So let us pray about our community. Om Sahana Bhavatu Sahano Bhunaktu Sahaviryam Karvavahai Tejasvina Vidhitamastu Ma Vidyusavahai ओम शांति शांति शांति। इसका अर्थ ये है कि हम सबकी ईश्वर साथ साथ रक्षा करें। हम जो लोग सीखें, जो पढ़ें, उस विद्या के फल का साथ साथ हमें भोग कराएं। हम जो पढ़ रहे हैं, जो पढ़ना चाहते हैं, उस विद्या की प्राप्ति का सामर्थ्य हमें प्रदान करें, और जो भी हम पढ़ें हमारा पढ़ा हुआ तेजस्वी हो और हम एक दूसरे से द्वेष न करें। तो this is the key point of the community mental health, because if there is hatred, if there is jealousness, if there is feeling for anything envious to the other people, our mental health got disrupted in near future. Before going to the main topic, I want to read disclaimer. This presentation is made for academic purpose, not for any kind of commercial activity. I believe that the knowledge that I am going to share with you is not the final truth. It is an attempt to tell as much as I can understand by studying. You are free to agree or disagree with me. If you wish, you may develop your own understanding by this of your studying the reference text on which I am speaking, or you may study other standard texts for your enlightenment. Outline of my talk is what is the mental health and well-being, what is the community mental health and well-being, and what are the current status, promotion of mental health and well-being, and challenges and future perspective with respect of the Indian population about the community mental health. If we see the definition of the health, which was given by the WHO in 1998, this is the health is a dynamic state of complete physical, mental, spiritual, and social well-being, and not merely absence of disease or infirmity. Whereas in Indian context, in Ayurveda, it was given that swasmin tishtati iti sastha, स्वस्थ जो अपने आप में सुख स्वरूप आत्मा में स्थित हो वही स्वस्थ कहलाता है। सुसूत्र संहिता में जो डेफिनेशन दी गई वो कहा गया समदोष समाग्निष्ठ समधातु मलक्रिया प्रसन्नात्म इंद्रिय मना स्वस्थ इत्यभिधेयते, जिसके तीनों दोष वात पित्त कफ और जिसकी जठराग्नि सम हो, जिसकी धातुओं रक्त रस मांस मेद अस्थि मज्जा शुक्र की क्रिया सम हो, जिसकी आत्मा इंद्रियां और मन प्रसन्न हो, वह स्वस्थ कहलाता है। और पद्म पुराण में कहा गया बुद्धि स्वास्थ्यम मन स्वास्थ्यम स्वास्थ्यमेन्द्रियकम, तथा जिसकी बुद्धि मन और सभी इंद्रियां स्वस्थ हो, स्वस्थता को धारण करने वाले हो, वह स्वस्थ होता है। If we are comparing this definition, the definition given by the WHO, it is the definition of the health, swasthya, which is an abstract thing, and it is dependent on the other component like social well-being. If a person want to be healthy, he is dependent on others. What the social person, what is the other person is behaving like that, and thus this is dependent and so unachievable also, and definition is incomplete, because if you are adding a spiritual component later, then what about economic, political, and environmental component of the individual? Whereas in our Indian consent definition, the definition is given for स्वस्थ व्यक्ति के लिए दिया गया है, जो कि एक इंडिविजुअल चाहे तो अचीव कर सकता है, ये इंडिपेंडेंट है और उसको पाया जा सकता है। What is the psychosocial well-being and what is the definition of mental health regarding this? WHO again defined in 2004 that mental health is a state of well-being in which the individual realizes his own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make contribution to his or her community. And in 2015, article published in the World Psychiatry Journal, where it was recommended that dynamic state of internal equilibrium, आंतरिक संतुलन जो है जोड़ने की आवश्यकता है, इस definition में this is incomplete. What is community? Wikipedia says that a community is a social unit with commonality such as common norms, common religion, common values, and custom or identity is common in the community. Whereas in other definition given in the dictionary that a group of people living in same place are having a particular characteristics in common called as community. So what is the history of community mental health? In 1960s, US President John F. Kennedy introduced this term community mental health, and after that in 1963 he gave a community mental health centers act in his country, and in 1967 Kaplan give principles of community services, and these principles are responsibility to a defined population, treatment close to the patient's home, multidisciplinary treatment approach for the people, and continuity of care. There should be not a break in treatment, whatever individual is taking for the mental health problems. There should be a consumer participation, and services should be comprehensive in nature. And components of community mental health model, if we see, the main component is awareness generation activity. Second is promotion of positive mental health across the different section of the community. Psychoeducation to religious organizations, self-help groups, faith healers, and local bodies. As in our Indian culture, it was seen that most of the population suffering from the mental illness, first time they want to get, they used to go the faith healers for their problems, and focus on stigma reduction. Rehabilitation services is need to be established, and services which is established is easily accessible, and linkages with the primary health care and tertiary care hospitals, social welfare, and state legal services authority is required. And protection of the human rights of the mentally ill person is to be taken care of. And how can we achieve the community mental health program? By public health services and by the health promotion services. And in both services, psychoeducation component and awareness component is common. Yes. And what are the impact indicators of mental health needs of the community? If there is a reduction of the treatment gap, reduction in stigma, reduction in suicide rates, reduction in death rates due to overdose of substances, reduction in violence due to mental illness and substance use, and rehabilitation of person with chronic mental illnesses, and reduction of violence in the community and schools are found, then we can say that the community mental health program is running well in our country or in any state of the our country. And what are the models which are initiated in our India for the community mental health? Basically, integration of mental health into primary health care services, and initiation and early experiences, composition of the team, treatment offered, linkages with the community. These are the component of the integration of the mental health into primary healthcare services. And second should be the services beyond hospitals, which can be available in the community. And community mental health model in India, it was initiated earlier in 1981 on the basis of two Indian studies done by Sakalwada in Karnataka and in Raipur Rani in Haryana. On the basis of the findings, the National Mental Health Program in 1982 was launched, and later District Mental Health Program was tested in Bellary district of the Karnataka, and after 1 year it was implemented as a pilot project in 4 districts in 1996 to 1997. In 12th 5-year plan increased this DMSP program, District Mental Health Program, into 123 districts of the country, and later after revision of the DMSP and NMHP, this district mental health program and national mental health program was incorporated with the national rural health mission, and now the plan is to extend it the district level in each district, DMHP in each district of the India, and by the government of India. As we are aware that in Uttar Pradesh there are many medical colleges are being coming in the near future, and we should optimistic that the mental health care is also going to be better, and their services is going to be better in near future in Uttar Pradesh. And if we see the what are the national mental health programs objectives, national mental health programs objective was to ensure the availability and accessibility of minimum mental health care for all in the near foreseeable future, particularly to the most vulnerable sections of the population, that is belonging to the poor socioeconomic status, to encourage and female and to encourage mental health knowledge and skills in general health care and social development, and to promote community participation in mental health service development, and to stimulate self-help in the community. And this program was planned to be initiated through the PSCs and CSCs. PSCs means public health centers, and community health centers. But there was a lack of coordination between these two programs. That's why the implementation and monitoring was not done properly, and the program not achieved their goal properly. Later, when it was incorporated in the district mental health program in NMSP with the objectives that to develop and implement a decentralized training program in mental health for all categories of health personnel in a way that would be the least disruptive to ongoing general healthcare activities. Second, to provide a range of essential drugs for the management of persons with mental illnesses, and to develop a system of simple recording and reporting of care of mental health personnel. And we are using eSanjeevani portal and government portal, ERS portal for the information, updating the information of the patient on the website. And other objectives are to monitor the effect of service of the mental health program in terms of treatment utilization and outcomes, and to reduce the stigma through public health education. Other objective is treatment and rehabilitation of patients within the community by adequate provision of medicines and strengthening the family support system. And later, DMHP was monitored by the government authorities, and in 10th, 11th and 12th 5-year plan, there was a huge improvement in these services, and the budgetary allocation increased to the 1,319 million rupees in 2002 and 2007, between 2002 and 2007, and it was the 5 times more than 9th 5-year plan. And DMHP was extended to 110 districts, and upgradation of psychiatric wings of 71 medical colleges and general hospitals was done, and 23 mental hospitals were modernized during the 10th 5-year plan of the government. And in 11th 5-year plan, DMHP was revitalized with the provision of the following. What? There should be a program officer, a psychiatrist, and a family welfare officer in each district for the coordination of the district mental health program. There should be 10 beds for acute care. There should be essential drugs in PSCs and CSCs, and also there should be more advanced drugs like lithium valproate, carbamazepine, benzodiazepines, and injection haloperidol and risperidone, etc. in district level hospitals. And training is essential for the medical officers, and establishment of 11 centers of excellence by upgradation of mental health institutions and hospitals, and setting up and strengthening 30 units each of psychiatry, clinical psychology, social worker, and psychiatric nursing in these setups. In 12th year plan, there are some principles were added for the implementation of DMSP in an effective manner, and it was the life course perspective, giving attention to the unique needs for children, adolescents, and adults. That's why RK program, Rashtriya Kishore Swasthya कार्यक्रम was initiated, and Rashtriya Bal Kishore कार्यक्रम was also initiated from the government. And second, recovery perspective, provisions of services across the continuum of care and empowerment of persons with mental illnesses and their caregivers, equity perspectives, accessibility of services to vulnerable groups and geographies, and evidence-based perspective. It means service provision through established guidelines and experiences only, and health system perspective, if we see that clearly defined roles and responsibility for each sector, whether it is private, whether it is government, whether it is the NGO, or the care providers, and right-based perspective, ensuring the rights of persons with mental illness are protected and respected. When it was monitored, later stages of the its commencement, it was found that there are limitations in DMSP program. The limitations are their poor community involvement is there, because stigma is present, and people not want to come to the mental setup or mental health clinic for the treatment, and inconsistent fund flow, and inadequate human resource and training, non-availability of crisis management and inpatient services, and non-availability of drugs in PSC and CSC level. These are the limitations of DMSP was found. And there are some lacunae also, and these lacunae are, there is inefficient monitoring and evaluation of the program. There was not clarity of objectives. Hospital management information system was not adequate, and technical support for information, education, and communication is not available, and continuity of care in the community is disrupted during the treatment program. But it was very good that in current scenario, the DMSP program is running in 517 districts of the country. The team is psychiatrists, psychiatric nurses, psychiatric social work, clinical psychologists, and ancillary staff. It was given to the community mental health model program in DMSP, and treatment offered, I have already discussed, essential drugs and brief psychosocial intervention, and for minor mental health problems is given to the community members on the health camps, etc. And linkages with the community, that is linkages with the training of auxiliary nurse midwives, accredited social health activists, and PSC level paramedical staff is envisaged during the program for the better implementation of the mental health programs. And for community mental health models in India, not only the hospital-based services is required, services beyond hospitals is also required to cater the need of the population who are suffering from the mental health problems, and it can be catered to provide community outreach clinics, through community camps, through crisis resolution and home-based treatment, through self-help groups, through therapeutic community, through tele-counseling, through halfway home and daycare centers, and developing home for mentally challenged and mentally ill destitute. And of course, the program Ayushman Bharat and Ayush is also giving fund for the treatment of the mental health problems. And we have seen that in the corona pandemic, many of the telecounseling services from Indian Association of Clinical Psychologists, from IMHRC also, there was helpline available, and many helpline was available for telecounseling. And there was the telecounseling services guideline also available from the NIMHANS Bangalore. This is a publication of Snehal Gupta and Professor Rajesh Sagar, in which they narrated a review about the National Mental Health Program, and they found that the National Mental Health Program has lack of coordination between National Mental Health Program and National Rural Health Mission, NRHM, sorry, ये MH लिखा हुआ है, NRHM, National Rural Health Mission, and now the National Mental Health Program is being monitored by the Niti Aayog. Now we can expect some more monetary benefit in the mental health program, and they recommended in this paper that there is a need for regular monitoring and evaluation, and if required, mid-term correction for the proper implementation of the National Mental Health Program. In this paper, they have also mentioned that in India, at present, psychiatrist is available on per lakh population is range from 0.05 to 1.2. This is huge service delivery gap for the mental health problems. And if we see the Desai's report, NG Desai report 2004, he has given the manpower requirement for mental health in India that one psychiatrist for per 50,000 population, one for 25,000 population for clinical psychologist, one per 25,000 population for the psychiatric social worker, and one psychiatric nurse for the 25,000 population. So thus we see that there is huge gap, and many courses are being run, and many Rehabilitation Council of India initiatives for the different kind of MPhil clinical psychology training programs in our country. And I have found that about more than 43 institution of the India is providing the mental health care workers training program, especially in clinical psychology, to cater the needs of the clinical psychological problems in the individual. And if we see the mental health morbidity in adolescent, it was found to be about 20%, and lifetime prevalence in adults is ranges from the 12.2% to 48.6%, and in among older adults it is 20% of our population. And the urban mental health and rural mental health initiatives was taken by the NG Desai from New Delhi, S.C. Tiwari from Lucknow, and S. Nambi from Chennai, and for the adult population. And Lucknow urban elderly study was initiated by the Professor C. Tiwari. I was also have worked in this project, and in rural mental health, Lucknow rural and urban elderly project is also initiated by the Professor C. Tiwari, and we found that about 17.34% of the older person is having some or other kind of mental health problem, and it was more common in lower socioeconomic status and in female population. And in rural population, the prevalence was quite higher, in about 23.7% among the older adults, where mood disorders is more common, and 2.8% dementia was found in the rural community of the Lucknow population. Yes, without talking about the suicide, if we're talking about the community mental health, it is not justice to the topic. So here, this is the screen of the Professor Sarbjit Singh, who is a professor in Agriculture Institute of the Punjab, and he given a model, multifactorial etiology of farmer suicide, where he gave 7 Ds, that the reason is death, depression, death, disputes, diseases, drugs, and disrepute. is the reason for etiology of the farmer suicide. And he also claimed that there are 7 R's which can be preventive and protective factors to uh, the suicide of the farmers. And these are the remunerative agriculture, resilience building, reassurance through connectedness, righteous conduct, religious support, responsible reporting, and rational expenditure by the farmers. Okay, these are the current study that depression is prevalent in 25% in community in COVID-19 period, PTSD, and anxiety is prevalent almost 28% in PTSD and 21% to anxiety and 20% depression. And new policies and act is also um, introduced in near in the current scenario, that uh, National Medical Council, which was earlier MCI, Medical Council of India. So they are approaching to the new medical colleges and private hospitals to give the recognition if they are completing their norms. And new education policy is also initiated, and here the focus is for skilled based training. Rehabilitation Council of India is running 34 institutions for MPhil in clinical psychology program, and many are in row for recognition. And Mental Health Care Act in 2017 was launched to deal with those problems which was not taken care of in previous Mental Health Act. And central and state mental health authorities are being also uh, in a row for their commencement. And in recent development is the National Commission for Allied and Healthcare Professional Acts in 2021, in which behavioral health science professionals can be recognized, and where the psychologist is the major part of it. The psychologist, behavioral analyst, and healthcare educators, and also the clinical psychologist is still is governed by the Rehabilitation Council of India. But this step can provide us more mental health professional to cater the need of the community problems. And WHO says that there is 4 A's for the implementation of the health promotion, and 4 A's are availability, accessibility, affordability, and acceptability of the health services in any sector. And in my opinion, there should be one more A, that is appreciability. If we cannot provide the service which can be appreciated by the people, the service is not going to see its success dawn. And Ayushman Bharat Health Infrastructure Mission is launched before 5 days. And yes, and today in G20 summit, One Earth and One Health slogan was given by our honorable Prime Minister Narendra Modi ji to cater the need of the community health as well as mental health program. In my way, the way forward for the community mental health is the revising the definition of health and mental health is required, so that everybody can be healthy. In inculcating the socio-cultural aspect of each individuals, and emphasis on lifestyle changes, as Professor Mehdi sir described earlier in his lecture. And awareness generation activity is required in each level. Indigenous concepts like ancient Indian thought. He also recommended about the pranayam. I also recommend doing yoga and reading Srimad Bhagavad Gita concept and practicing. It is very good to maintain our psychosocial well-being and mental health. And use of vernacular language in teaching and training. हम जिस भाषा में सीखते हैं, जिस मातृभाषा में सीखते हैं, तो हम कम मेहनत में सीखते हैं, अच्छे से सीखते हैं, बेहतर से सीखते हैं, और अच्छे से सोच पाते हैं, और अच्छे से आगे बढ़ पाते हैं उस चीज को लेकर के. तो ये जरूरी है. एंड टू फिलफिल गैप्स इन सर्विसेज, I have earlier discussed, and I think that charity begins at home, and thus we used to start healthy thinking, healthy behaving, and healthy expressing to care of our mental health as well as other mental health. And judicious use for newer technology, print, electronic, and social media for awareness generation activities required, and thus we in future will be able to cater the needs of the community mental health program. There are the many helplines for the mental health program services. And yes, e-Sanjeevani portal is also is being initiated in COVID-19 period, and successfully everyone who is digitalized, who is using a smartphone, and if not using, you can cyber cafe you can use, and from there you can take consultation of your problems from home. And I acknowledge all gurus, parents, friends, Reputation Council of India, IMHRC, our e-library, and COVID-19 also, because we are interacting with this forum, Zoom meeting forum, due to COVID-19. Otherwise, we have met in personal in the conferences. Thank you. These are my reference texts. Thank you. Thank you very much. Yes, in previous session, Hina Nishat asked a question, and sir very rightly replied that कि एक reinforcement technique कि कुछ भी उनको इनिशिएट करिए, काम करने के लिए उनकी प्रशंसा करिए. तो एक श्लोक है जो हम लोगों में कॉमन है कि अभिवादनशीलस्य नित्य वृद्धोपि सेविनः चत्वारितस्य वर्धन्ते आयुर्विद्या यशो बलम, कि जो लोग विनम्र होते हैं, शीलवान होते हैं, बुजुर्गों की सेवा करते हैं, उनकी 4 चीजें बढ़ती हैं. आयु बढ़ती है, विद्या बढ़ती है, यश बढ़ता है और बल बढ़ता है. तो हमें पूरी कोशिश करनी चाहिए कि हम अपने बुजुर्गों की सेवा करें. बहुत बहुत धन्यवाद.
Thank you, sir. Thank you so much. I'm Hina, sir. Sir,
Thank you. I was listening your question. That's why I have replied.
Yes, I have another one question for you, sir.
Yes, yes. Please ask.
सर एक चीज तो ये पहले जो अभी हमने सर से पूछा था, मैनवी सर से, तो सर मुझे ये चीज जो आप लोगों ने बताया कि हम उनसे बोल रहे हैं कुछ करने के लिए, तो अभी तक हमें ये लगता था कि मतलब उन्होंने हमेशा हम लोग के लिए किया, तो हम सब काम खुद ही करते हैं, मतलब हम कहते हैं नहीं आप नहीं करिए. तो मुझे लग रहा है ये एक नेगेटिव चीज हो गई उनके साथ कि उनको कुछ ना करने देने की वजह से वो और ज्यादा वो सोच मतलब कुछ करना नहीं है तो वो सोचना ही है उन्हें हर वक्त कुछ ना कुछ.
यस 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 हिना, बिल्कुल सही बात है. देखो, जब हम लोग डील करते हैं ना एल्डरली पॉपुलेशन से, तो ABC पे डील करते हैं. ए मींस एक्टिविटी ऑफ डेली लिविंग, यानी नियमित दिनचर्या. बी है बिहेवियरल और सी है कॉग्निशन. ठीक है. तो एक्टिविटीज ऑफ डेली लिविंग का मतलब कि सुबह से लेकर के शाम तक जो उनकी सामान्य दिनचर्या है, उस दिनचर्या को उनको करने देना है. आप उनमें उनकी उतनी हेल्प नहीं, मतलब उनको डिपेंडेंट ना बनाइए. जितना वो कर सकते हैं उतना करिए. जितनी फिजिकल एक्टिविटी होगी तो उतने फिजिकल डोमेन होंगे. हाँ, सर ने जो बताया था, मेहदी सर ने, कि आप उनको अप्रिशिएट करिए, उनकी प्रशंसा करिए, है ना. तो उनका मन खुश होगा कि ठीक है मैं कर सकता हूँ. थोड़ा उनके लिए टाइम निकालिए, उनके लिए बाकी डायलॉग इज नेसेसरी. ठीक है, बातचीत करना बहुत जरूरी है. टच करिए, पैट करिए, गले से लगाइए. ठीक है. तो ये सब चीजें अगर आप उनके साथ करेंगे तो ठीक रहेगा. आपके घर में अगर पुरानी एल्बम्स हो, ठीक है, तो उन एल्बम्स को निकाल के बैठिए, किसी दिन छुट्टी के दिन उसको पलटिए, उनके साथ डिस्कस करिए, बातें करिए. तो देखिए उनका जो है इमोशन भी इम्प्रूव करेगा. उनका कॉग्निशन का मतलब मेमोरी फंक्शंस है, ठीक है, अटेंशन कंसंट्रेशन है, एग्जीक्यूटिव फंक्शनिंग है, तो वो भी इम्प्रूव करेगा. हम उनसे पूछो, अरे जो भी है, अम्मा, दादा, काका, दादी जो भी हैं, उनसे पूछे कि अरे ये किसकी फोटोग्राफ है, ये कब की है, तो वो घटनाओं को ना सोचेंगी, बताएंगे, तो मेमोरी फंक्शन इम्प्रूव होगी. ठीक है. साथ ही उस मोमेंट को उस पल में जी रही होंगी, तो उनको ऐसा लगेगा कि अरे हम, उसमें खुशी महसूस होगी उनको. ठीक है. और इसके साथ साथ आपकी भी नॉलेज बढ़ेगी ना चीजों के बारे में.
यस सर, श्योर सर, थैंक यू सर. सर एक चीज मुझे पूछना था आपसे कि सर जैसे आपने बहुत अच्छे से सारा, बहुत वेल प्लान था सर एकदम आपका प्रेजेंटेशन, इससे बहुत कुछ सीखा हमने भी कि किस तरह से. सर जो आपने स्पेशली शुरू में मेंशन किया वो जो कि दिस इज फॉर सर, वो बहुत अच्छा था. मुझे लगा कि वो चीज हम लोगों को करना चाहिए प्रेजेंटेशन में अपने. सर दूसरी चीज जो आपने ये हेल्थ प्रोग्राम के बारे में बहुत सारी चीजें बताई हैं, तो जैसे हम आज आपका लेक्चर सुन रहे हैं तो हमें बहुत नई चीजें पता चली उसके बारे में. तो हमें लगता है कहीं ना कहीं अभी भी ये सारी जो स्कीम्स हैं अभी भी सिर्फ पेपर्स, कागजों, बैनरों तक नहीं लिमिट है. सर आपने बताया लखनऊ तो एक हमारा अर्बन एरिया वहां पर भी रूरल, जो लखनऊ का रूरल एरिया, वहां पर इतना ज्यादा मतलब लोगों को मेंटल स्ट्रेस है लोगों को बहुत ज्यादा, और वो रिकग्नाइज भी नहीं कर पाते हैं कि अभी हमको मेंटल प्रॉब्लम है। उनको तो लगता है कि हाँ हमको ये प्रॉब्लम। तो सर इसका एक मतलब एक इम्प्लीमेंट हो जाए, मतलब लोगों तक वाकई में पहुंचे। जैसे सर हम करामत कॉलेज में पढ़ाते हैं, तो हमारे कॉलेज में अभी हुआ था एक मेंटल का एक कैंप लगा था, उसमें बच्चों की काउंसलिंग हुई। जैसे हम पढ़ाते हैं तो हमारे स्टूडेंट्स भी मुझे लगता है कि उनकी एक काउंसलिंग की बहुत जरूरत है। उनको समझ में नहीं आता, अगर उनकी प्रॉपर काउंसलिंग हो जाए तो दे विल डू इट, बहुत कुछ कर सकते हैं। हम लोग ब्लेम कर देते हैं कि बच्चे ऐसे ही हैं, इनको कुछ नहीं आता है, बट दे नीड काउंसलिंग, मतलब एक साइकोलॉजिकली इस तरह से। तो सर क्या कर सकते हैं हम लोग, क्या कर सकते हैं इसमें?
बहुत ही रिलेवेंट क्वेश्चन तुमने पूछा है।
थैंक यू सर, थैंक
सबसे
यू
पहले
सर।
मैं ये रिप्लाई कर दूं कि जितने भी प्रोग्राम्स लॉन्च हुए हैं
जी
वो
जी
सब
जी।
चल रहे हैं, ऐसा नहीं है कि वो कागजों
नहीं
में।
नहीं, बिल्कुल
जैसा आप
बिल्कुल।
पूरी बात सुनो मेरी। अच्छा, जैसे
ओके।
मैंने बताया कि जितनी हमारी पॉपुलेशन है, उस पॉपुलेशन के अनुपात में जितने भी हमारे मेंटल हेल्थ प्रोफेशनल्स हैं, चाहे वो साइकेट्रिस्ट हों, चाहे क्लिनिकल साइकोलॉजिस्ट हों, चाहे साइकोलॉजिस्ट हों, चाहे सोशल वर्कर्स हों, चाहे काउंसलर हों, वो कम है। तो जाहिर सी बात है, जब कम है और उनके पास भीड़ ज्यादा है तो वो सब तक नहीं पहुंच सकते। ठीक है, तो सबसे पहली बात यह है कि इन लोगों को ट्रेनिंग देना, ठीक, ट्रेनिंग दे करके और उसके बाद उनको वहां पर भेजा जा सकता है। और अनट्रेन्ड लोग अगर जाएंगे तो प्रॉब्लम को वर्से नहीं करेंगे, खराब ही करेंगे। ठीक है ना। तो जो मैन पावर ट्रेनिंग चल रही है अभी, जैसे हमने कहा कि नया जो कमीशन अभी बना है हेल्थ केयर अलाइड प्रोफेशनल का 2021 में, उसमें क्या है कि उसमें साइकोलॉजिस्ट को इंक्लूड कर लिया गया है कि इन लोगों को नियर फ्यूचर में इन सारे कामों में लगाया जाएगा, उनको थोड़ा सा प्रॉपर ट्रेनिंग दी जाएगी। ठीक है, तो इस तरीके से हमारे पास जो है एक बल्क ऑफ हेल्थ मेंटल हेल्थ प्रोफेशनल्स होंगे। डिस्ट्रिक्ट मेंटल हेल्थ प्रोग्राम की बात हमने कहा कि 517 डिस्ट्रिक्ट में भी चल रहा है। ठीक है, अब जैसे जो प्लान है नियर फ्यूचर में कि अब जैसे उत्तर प्रदेश की बात हम करें तो उत्तर प्रदेश में जो नियर फ्यूचर में प्लान है वो है कि हर एक डिस्ट्रिक्ट में एक क्या होना चाहिए, मेडिकल कॉलेज होना चाहिए। तो जो इम्फेसिस है नेशनल मेंटल हेल्थ प्रोग्राम का कि हर डिस्ट्रिक्ट में एक यूनिट भी होना चाहिए, साइकेट्रिक यूनिट होनी चाहिए। तो साइकेट्रिक यूनिट होने का मतलब एक साइकेट्रिस्ट होगा, क्लिनिकल साइकोलॉजिस्ट होगा, साइकेट्रिस्ट सोशल वर्कर होगा, नर्स होगी, काउंसलर्स भी होंगे। ठीक है, तो इस तरीके से नियर फ्यूचर में प्लान हो रही है और आगे चीजें अच्छी होने वाली है। अब मैं आपको बताऊं इनिशिएटिव्स के लिए, मैंने आपको बताया था अर्ली आइडेंटिफिकेशन सिम्टम्स के लिए हमारे यहाँ केजीएमयू साइकेट्री में जो है एक पूरा सेंटर चल रहा है। ठीक है, रायबरेली में डीएमएचपी प्रोग्राम चल रहा है। जितने भी नियर बाई जो डिस्ट्रिक्ट है, अगर आप देखेंगे सीतापुर में चल रहा है, प्रोग्राम्स चल रहे हैं। लेकिन हाँ, स्कूल मेंटल हेल्थ प्रोग्राम्स, कॉलेज मेंटल हेल्थ प्रोग्राम्स ये भी इनिशिएट किए गए हैं और ये चल रहे हैं, लेकिन
यस
लेकिन बर्डन बहुत ज्यादा है। ठीक है, अब मैं आपको बताऊं कि जैसे हमारे यहाँ किंग जॉर्ज मेडिकल यूनिवर्सिटी में एक डीन स्टूडेंट वेलफेयर होता है, तो उन्होंने अभी इनिशिएट किया है स्टूडेंट काउंसलिंग सेंटर, जिसमें जो है 3 कंसल्टेंट जा रहे हैं आज की डेट में, जिसमें एक मैं हूँ, एक डॉक्टर 4 कंसल्टेंट है। मैं हूँ, डॉक्टर निशामणि पांडे हमारे डिपार्टमेंट से, डिपार्टमेंट ऑफ साइकेट्री से डॉक्टर पूजा महौर और डॉक्टर श्वेता सिंह है। तो ये जो है ये ईच डे 1 आवर की जो है ओपीडी दे रहे हैं अपनी, वहां बच्चे आ रहे हैं। तो इस तरीके से हर एक स्कूल में एक स्कूल काउंसलर होना चाहिए। ठीक है,
यस
कि बच्चे अपनी प्रॉब्लम शेयर कर पाए। तो अभी ठीक है, प्रोसेस है, चल रहा है, समय लेगा, क्योंकि अभी
यस
जनरल हेल्थ की ही इंफ्रास्ट्रक्चर इतना लूज है, इतना कम है कि मेंटल हेल्थ तो फार फार दूर है।
यस।
अगर अगर
थैंक
अगर
यू, थैंक यू सर, बहुत अच्छा आंसर दिया आपने, थैंक यू सर।
थैंक यू। एनी अदर क्वेश्चन?
Thank you very much, sir.
Thank you, Sajid, for
Especially
giving
the deliberations and especially the updates on the community mental health programs, national mental health program, as well as the district mental health program. So we look forward towards a scenario in which we will be having the facilities of mental health professionals in each and every district, so that the burden on each and every professional is shared. Because nowadays, as the data you shared, we are not as per the parameters of the Commonwealth parameters. जो एक ग्लोबल पैरामीटर्स हैं उनके बेसिस पे स्टिल वी आर लैगिंग अ लॉट. For example, in a place where we have thousands of individuals or registered professionals, there should be more. So we look towards a scenario where the governments as well as the concerned authorities take up the matter and come up with certain different programs. Although there are many programs being run at the district mental health level, the dawa and where I think it was related to the some spiritual techniques being added to it, where they have incorporated the services of mental health professionals along with the spiritual healers. So I think these kind of activities are also incorporated nowadays. So let's see how the things are changing. And
Yes, Dr. Sajid, on mazars and on
yes, sir.
temples, है ना? Temples where they used to go there.
दुआ से
team
दवा
of
तक समथिंग
yes,
इस तरह के
yes,
कुछ
team
टाइटल
of the psychiatrists, psychologists are going there and create awareness for the mental health problems, है ना? Okay,
yes,
so let us hope future will be better. Okay,
definitely, sir.
thank you.
Thank you very much, sir. Thank you very much, and especially the discussions. And just one thing, as Professor Zaidi sir always teaches that ये वक्त भी गुजर जाएगा. So whenever we face any difficulty, any kind of challenges, so just we should be hopeful that the things will be better in the end. Thank you for your time,
This is
sir.
a positive approach, है ना? ये वक्त भी गुजर जाएगा, हाँ? Good, very good. Thank you.
Thank you very much. Over to my esteemed colleague Nandini madam.
A very good afternoon to all my esteemed guest present here and all the enthusiastic participants who have been very patiently and cooperatively been a part of this conference since yesterday. So a very warm welcome. I'll take this opportunity to introduce myself. I am Nandini Sharma, Assistant Professor and Clinical Psychologist at Amity University, Uttar Pradesh, Lucknow. So moving towards the next session, our next lecture will be taken by Professor Dr. Abul Hussain. Taking this opportunity to introduce Dr. Abul Hussain. He is an Associate Professor and Chairperson, Department of Sociology, Green University, Bangladesh. With an expertise in the field for more than 15 years, Sir has been former Associate Professor in Developmental Studies, United International University and Daffodil International University, Dhaka, Bangladesh. He has been the former Chief Executive of Development Link Foundation, Dhaka, Bangladesh, and Senior Research Fellow at Power and Participation Research Center, Dhaka. So with this, I would want to hand over the platform to Sir, and I would request you to kindly proceed with the lecture. Thank you.
So let me give permission as co-host so that I can present myself. Okay.
Sure, sir. We're doing.
Okay. Yes, you have already introduced me in short, and I am delighted to be here. In fact, many scholars and many professionals in health sector, beyond health sector, I would say, are present here, and I'm learning from you a lot of things. So I was very much concentrated with the lecture of Professor Mahdi and also Rakesh Tripathi. Very excellent, I would say. I have learned a lot. So I would like to thank you to the IMHRC and the organizers also here to invited me. And I am, very much happy to be here, in fact, with you. So my presentation, in fact, that was assignment, I would say, Sajid, in fact, give me this assignment to do. So last night I sent the PowerPoint presentation and also my paper there. So I'm going to start because of only 20 minutes here. So very constrained time, very difficult to talk about the total, social determinants phenomena. So I think so the contents I'm going to discuss in front of you. So what exactly we understand about the social determinants of health, and what's the social determinants of gaining a global foothold. This is also important. And the social determinants of health in India and Bangladesh. I'm sorry, I was failed to total discussion in the Asian perspective. Though it's an international conference, but I concentrated only India and Bangladesh. And what are the major challenges implementing the social determinants? These are my contents, I would say. Let me talk about what are the exactly social determinants of health. I think all you are present here, you know very well about the social determinants of health, but I would like to say, I need to point out some, it's non-medical factors. Obviously, all the, health management, stress management, all things are obviously linked to the non-medical factors. And obviously, as Rakesh Tripathi highly mentioned, in fact, the lower socioeconomic segments are very suffering on mental. But I would say there are many, economic and social factors embedded with the non-medical factors, economic, social factors, distribution of income, wealth, etc. are very important, influence the power, in fact. And if I say politics is in the South Asian countries, also very important in understanding the social determinants of health. So exactly, if I read it, that this unequal distribution of health damaging experience is not in any sense of a natural phenomena, but it is also a result of the toxic combination of poor social policies, etc. So let me, keeping the time in my mind, let me talk about a little about how social determinants of health gain a global foothold impact. So there is a contested field, you know well, because the fact is, it is very big and vast field, but within a short time, it's difficult to express all the things. But my understanding also, I didn't mention in my paper though, that in Indian society, there was, thousands of years back, there were informal social determinants existed at the time, in fact. So the people is very much, living in the urban and rural societies, and earlier all in rural societies, they also somehow, manage that they also address the social determinants on their own way. The community capacity also important there. So something wrong, let me, okay. So in the global foothold I am talking about, there in early 2000, academics and politicians work on social determinants. There was, you can say, the global attention was there, in fact, under the UN, in fact. And that resulting in 2000s, resulting in comprehensive understanding of global health disparities. That was important. This is a non-medical factors. Social determinant is a non-medical factors that influence health, in fact. So what are the non-medical factors? That was in fact, important for those global leaders, I would say, the WHO, in fact. So who defined first that in early 2000s, there was work on social determinants. In 2003, they had a little on that, the social gradient and social exclusion, work unemployment, and social determinants of health. These are the three major factors, social inclusion. And there was much discussed, in fact. I was in London, in fact, at the time. So we did discuss a lot of on the social exclusions. So how can be included people from that very deviant behavior or social exclusion for many regions. That was also important at that time. So not finally, but in 2008, there was a big study, in fact, and that was, in fact, closing the gap in a generation. There was under the WHO, in fact, that conducted the very studies. There was found, in fact, the daily living conditions, distribution of powers, money, and resources. Those things come from that very study. And in 2011, that was, you can say, there was a big declaration. It's called a Rio Political Declaration on Social Determinants of Health. And that, in fact, new policies across the world that was started, in fact, and all over the, mainly in developed, we are sometimes talking about the developed countries, but mainly this focus on the underdeveloped countries like ours, in fact. That is very important, because if you go that very in Canada, then you can find many social determinants are already achieved, and they are not struggling like us, our South Asian and African countries. These are very important things. So what are the major determinants in India and Bangladesh? This is a vast topic. I know there will emerge a lot of questions. There are other social determinants also, but I'm just trying to concisely talk about the social determinants in India and Bangladesh. I know myself, there are other many things, but the important social determinants in India, I would say the air pollution, air pollution, child undernutrition, that is also important, and unimproved sanitation, employment conditions, gender inequality. These are in India, these are the very, burning issue still in India. Obviously, there are policies, you can say, there are policies, obviously, but from recent studies, you are familiar with those, in fact. There is a good study, I would say, that very indoor air pollution, for the women and children, those who are near to stoves, or they are suffering. Child undernutrition is still in India. There is many policies also, and even very well, but still that very child undernutrition is existing, in fact. So have to address, in fact. Unimproved sanitation significantly in rural areas, still there is a big fight too. If I talk about this, not only in India, but also in South Asian, in Bangladesh also there is, but sanitation we call in Bangladesh, there is a 100% sanitation. But the thing is, the quality of sanitation, that is, you can say, in most rural areas, though in the, researchers and the, we know it in Bangladesh, sanitation is good, but there are many questions. I have some studies on Wellbeing. They're okay. There is a sanitation facilities and all these things, but hygiene problem is there. So these things are very important. And in Indian context, also the reducing child labor have, gained a lot, in fact. And there are many organizations, civil society, and also government, Indian government is trying to reduce the child labor, but employment conditions continue to be problematic also for the child. So now, state of major social determinants in healthcare in India and Bangladesh, and again, gender inequality in Bangladesh context, I am trying to say. There are many things too, but the main constraints or main issues we are trying to address, and difficult to address also, these are gender inequality. Women suffers in health in various regions, in fact, And education nowadays, the education is developing, but it's still the quality education is important here, and social status. So women in the local government, women in the various institutions, but the social status is still a question, in fact. And obviously, you have, in Bangladesh, there are a lot of women violence in different way. In fact, sometimes people here also talked about that the women violence against women, there is a burning issue. So we, Bangladesh here, I have visited many times in India. I know the women are, they are also a threat, but the thing is, in Bangladesh, we guardians, in fact, do not permit our girls, in fact, to go out at the after evening, sometimes in urban areas also. This is, I think, is still a problematic thing. It's linked to, many things, politics, political structure, and all these things. Influent insufficient human resources and health. This is one of the area we are suffering. And I know better in India, there are many Bangladeshis are going to get the treatment, including the mental health related diseases. Bangladeshis are going to India because of many things, but somehow one thing is they trust the Indian, especially South Indian doctors, somehow not that much in Bengal, West Bengal. And that is important in our health structure. And the Upazila we call sub-district level, there are doctors and other things. But if you go to a hospital, then you cannot find the very good X-ray machine and all these things. So these are very big things, and these, I would say, there are a very clear policy about that. That very policy is not working. Implementation in policies is difficult, I think. In some sense, in India, in some policies are not that much implementing also, but Bangladesh is a, dysfunctionalities in every institutional policies. There is a big, concern for us. Impact of climate change. This is also very important, and in from that Lucknow is very difficult to hear, but in Bangladesh, the Sundarban 2 times affected, and Bangladeshi peoples affected, West Bengal peoples also affected. Sidor and Ayla, these are called. So many peoples living that very places, and the sea water level is rising. And there are many climate change and affects the people, in fact, and these are somehow the displacement of people and, go to the migration, all these things are, causing, many, non-medical stress and other things linked to the major social determinants, I would say, in Bangladesh also. Because of that, arsenic contamination in West Bengal, India and Bangladesh is sometimes it's a very dangerous situation. In fact, the coastal belt mainly, there are people suffering a lot on the arsenic contamination problem, and there are many awareness programs and others are running. But I think this is still a very big problem to address because it's related to the water. And in the coastal belts, if you go, the saline water is also there. So when you are taking the pure, want to take the pure drinking water, that's a very challenge, in fact. And in Indian, some parts also, in West Bengal also, in the coastal belts, that is very important. So these are the issues now here, we can say in Bangladesh, the burning social social determinants of health issues. Obviously, there are many, you are getting ready to question me many things, but it's true. It's a not that very complete lecture, I can say. Anyway, what are the major challenges to implementing social determinants of health, especially in South Asia? I think in South Asia and our South Asian countries and society, what to do in fact. There are many things to do, but I very concisely, because of I have not many time in fact. So I think the policy formulations and implementation, this is very important. You can say there are many policies in India, and in Bangladesh, I would say there are many policies. But Rakesh mentioned that thing, in fact, the implementation problem and coordination problem. I think the same thing is happening in Bangladesh. Existing policies must be properly implemented. That's a big question. Coordination and implementation, many things are. Rigorous training and research must be incorporated. So training and research are very important in a different way, I think. New policies, sometimes Rakesh also mentioned that the Indian patients suicide. I also wrote a paper, the why people in Indian farmers are suicidal state. So there are many things you know very well, but the thing is the socio-economic position is the rich farmers are not suiciding, in fact. So why? That is poor, lower strata people are suffering, and the same thing is in Bangladesh. But the thing is, so because of that, galvanizing all these things need to take some new policies and management arrangements are required, in fact. In India, also, though it is Bangladesh context, but some true is in Indian context, I see. In order to address the social determinants of health, it is necessary to develop new and necessary policies. So policies are very important. If the governments are not taking the policies, then it is very difficult to implement. And we know the implementation stage in India and Bangladesh. There are many questions, in fact. But in Bangladesh context, I think in somewhat in Indian context, the same thing, same true is necessary in management. Management is big, questions. There are many management system and all these things, but still we need to. Corruption is, and in our countries, corruption in a different way. Political nepotism and crony capitalism, all these things are embedded with that very, implementation challenges. So that's almost, I'm going to conclude, in fact. Wealth disparities within and between social classes of population, as well as the political systems structures, are the predominant impediments of achieving health equity. That's true, I think, not in the first world countries or so-called, but in South Asian countries and also in African countries. These are very true, in fact. So it is crucial to consider the social determinants of health to gain health equity is important, and social well-being and development. So I think this is my short presentation. Some of you can agree with this, but I like the disagreement in many things because this paper is very short. Thanks a lot to you all.
Thank you so much, sir, for such an elaborate and detailed discussion on the topic of social determinants of health. You have spoken not in just regard of Bangladesh, but in regard of total Indian subcontinent, and have given an elaborate picture of the challenges faced in this area. So thank you so much, sir.
Can I give a quick comment?
Sure,
Sure. Professor Hussain, wonderful talk. And what I liked was that you mentioned about the very important toxicant, that is arsenic toxicity, which is prevalent in Bangladesh for a long time, and in India, Bengal also, but now in Uttar Pradesh, that is the part in which we are living, We are seeing
Oh.
many cases, and because of soil erosion, mining, and all that.
Hmm.
So, and it is more prevalent in rice eaters, those people who are eating rice.
Hmm.
The arsenic toxic. So, very interesting thing you have pointed out, and I think that is a very important social determinant, and that causes so much havoc, a lot many problems like cancer. I have reported one case report recently about
Yeah.
arsenic toxicity leading to cancer. So
Yeah.
that gentleman was from Balia in district in Uttar Pradesh, east of Uttar Pradesh, from where that patient came to us, and we diagnosed him and we treated him. Very interesting thing and very interesting talk. So compliments to you, and thank you for bringing this aspect also in your talk. Thank you so much. I was so happy to hear you talking about
Yeah.
this
Okay, thank
important.
you. I think the Uttar Pradesh arsenic problems were not that much familiar to you. I
Yeah.
think within Bangladesh and India, your part, we can take some studies. And my background, in fact, in 30 years, I have a research background. Before that, by teaching with the World Bank, LSE, and in Denmark, I stayed in fact many years. In fact, so there is a chance to collaborate. In fact, on the
Surely.
yeah.
Sure.
Thanks.
Thank you. Thank you so much.
Thank you so much, sir. So if you allow, may we move to our next speaker, sir?
Ma'am,
Sure.
hello,
Sure.
ma'am. I have a question.
Okay, sir, we have a question, sir. Yes, Hina, you may continue with your question.
Okay. Please raise your question.
Sir, your presentation was bhalo.
Hello. Bangali.
Yes, it's a very nice language, the Bengali. Sir, you are from sociology department.
Yeah, I'm the sociology department, and my honors, masters, MPhil, PhD all are in sociology.
Yes, sir.
And now I'm the head of the department of Green University of Bangladesh. It's a private university, but very good university.
Okay, sir. Thank you, sir. Sir, I'm also
My email and my email and phone number is there.
Sir, please post in chat box, sir. I will contact to you after the conference.
Sure.
Yes, sir.
Thank you.
Sir, okay, then I will ask you after the conference my queries. Okay, ma'am.
Yeah.
Because the time period is short, no, ma'am. I understand. Okay, sir. Thank you, sir.
Okay. Also,
yes, sir. Yes, ma'am.
I'm seeing the participants can post their queries in the chat box, and keeping in mind the time frame, we can address them accordingly.
That would be fine.
Yes, sir. Yes, sir.
Sir,
To manage the time.
Sir, please.
To manage time is stress.
Sir, please post your email and
Okay.
contact number.
Thank you, sir. Moving forward to our next speaker, Leila Flores Torres. Apologies from my end in advance if I mispronounce the name. So, Leila Flores Torres is the director and in Special Education Department, Sharyland Independent School District, Texas. Her work experience includes working with K-12 students with and without disability and working with university students with disabilities through the provision of accommodation that will ensure access to higher education. She has also worked providing mental health counseling to bilingual and Spanish-speaking clients, including working with unaccompanied, undocumented minors who migrate to the USA from Central America and Mexico. She has conducted outreach and health education and promotion to undeserved communities. She has been a lecturer in UTRGV School of Rehabilitation and College of Education. Dr. Flores Torres also have contributed to research work in the field of disability. With this, I would want to extend my warm welcome to Dr. Flores Torres. Over to you, ma'am.
Thank you. Can you hear me?
Yes, ma'am.
Okay. Well, thank you very much. It is a pleasure for me to be here today. Tonight for me, I want you to know that it is 12:56 in the United States AM. And so we are past midnight here, just past midnight. And it's exciting to be here. The first time I present at this time of the early morning. And I am appreciative to the organizing committee of this conference for allowing me an opportunity to be here with you today. And so with that in mind, I would like to share my screen with my presentation. Is that okay?
Sure, ma'am. Just give us 1 minute. We are making you the co-host. Ma'am, you can share your screen now.
Okay, thank you. Let me see. Can you see my screen? Sorry.
Yes, Dr. Flores.
You can, okay.
Yes,
It looks
yes,
like
we are
I'm
seeing.
working on.
We are seeing.
So do you see the front page, the well-being of children with special needs?
Yes, it's visible.
Okay, it's just that I'm working from two screens and I have the camera in one and the presentation in another one. So I'll be looking back and forth between the screens. So anyway, again, I am Leila Flores Torres. You pronounce my name okay. I do work with students with disabilities in kinder through 12 level of education for the Sharyland Independent School District. We are located in the state of Texas. Deep South Texas, we are about 1 kilometer distant from the border with Mexico, between Mexico and the United States. And so we are in the United States, but we're very close to the border with Mexico. Our population here is mainly of Mexican American descent, and which means that we have cultural diversity and linguistic diversity as well. The majority of our population speaks Spanish as a primary language and English as a second language. And so just a little bit of background about who we are here. I myself, I am from Mexican descent. And so mental health is as important, as we know, as it is physical health. And this is important to our quality of life. And mental health is not just simply not having a mental illness, but it is also having the skills that are necessary for us to deal with life challenges. And so again, not only not having a mental illness, but having the skills that we need to navigate our environments. If ignored, mental health problems can interfere with a person's life overall. But when we speak about children, it really interferes with learning, with social and emotional growth, and with academic growth and social environment overall. But what happens when we already work with children who have disabilities, and on top of that, they are diagnosed with a mental illness, for example, anxiety or bipolar disorder or ADHD. And so what happens when we have that interaction between a pre-existing disability that requires the use of special services or special education, and on top of that, we're diagnosed with depression, anxiety, bipolar disorder, or any other eligibility or any other condition. And so that becomes a challenge to work with children in the school setting. And so for that, we have in our environment, in our American educational system, we have a team of professionals who work with kids who receive special education and related services. And so I want to start by speaking about the role of the school psychologists, because those are the most important professionals when working with children who have emotional issues that impact their learning, and also who work with kids to develop their sense of belonging into the campus or schools, and also their well-being. So school psychologists and counselors are the ones that are equipped to facilitate the development and implementation of prevention and intervention efforts in working with children who have behavioral and emotional disturbances in schools. Also, the intervention and the prevention that school psychologists offer through the school-based behavioral and mental health programs help promote the psychological wellness for all children. It also helps improve their development and maximize their success in school, at home, in the community, and overall their quality of life. So we're looking at kids who have certain conditions that require special education, but who get an additional layer of support in the school setting, in which a school psychologist works with them to help them promote an overall sense of well-being. And this is important because, like in many countries, the American educational system is based on standards and expectations that students must meet. And this is regardless of them having a disability or a condition. And so the role of the school psychologist becomes really, really, really important and instrumental. So what we see in our educational system as the most common mental health problems was very different pre-pandemic. So 2 years ago, before COVID-19 hit our schools and our lives, the most common problems that we would see here in the schools are learning disorders, emotional disorders, anxiety was pretty frequent, attention deficit and hyperactivity disorder, and other behavioral problems, for example, oppositional defiant disorder. And again, these are all problems that we see in children in school age, from kinder all the way to 12th grade, which is high school. The panorama changed during and after COVID, because now what we see is a spike in and an increase in the number of students who have emotional and mental illness issues. And so now we see adjustment disorder, for example, with children who got used to being at home with remote instruction, and then they were expected to transition back to face-to-face education. And we're seeing some students who have adjustment disorder. They have separation anxiety from their parents. They don't want to leave home. A lot of students, I'm sure, across the United States and also the world, lost a family member. So we have kids who are grieving, and who, because they have lost a family member to COVID. We also see a lot of depression and a kind of like a pervasive mood of unhappiness in kids. We see, again, fears, oppositional defiant problems, eating disorders, addictions to drugs, for example, to gambling, to video gaming, other types of addictions. And we have seen an increased number of female students with self-mutilating behaviors, which means they cut their wrists, their arms, their legs, their stomach, whichever part of their body they get access to, and they mutilate. We also have an increased number of students who are at risk of suicide, and a couple of students in our school district who are also have homicidal tendencies or thoughts. And in general, we are seeing a lot of relationship problems, dating violence in adolescents. We have inappropriate sexual behaviors beginning at an early age. And again, the majority of our students were at home for over 1 year, almost a year and a half, due to COVID. And so we have seen an increase in mental health issues and a decrease in the overall feeling of wellness and happiness with the kids in schools. Students with disabilities or with mental illness are protected. There are laws that protect kids with disabilities. And so I just want to touch base briefly on the two of them, two most important ones. The first one is IDEA, the Individuals with Disabilities Education Act, and this one was reenacted in 2004. And it is a law that was set in motion by President George W. Bush some years back, and it makes available a free and appropriate public education to children who have disabilities in the school setting, and it ensures that they receive special education and additional supports at no cost to them and to their parents. I'm sorry. This covers eligible infants. So we start working in special education with kids who are 1 year old if they are deaf or blind, and with toddlers if we suspect that they have a condition such as autism, intellectual disability, or other types of disabilities that require them to get an early start in school. And then beginning at the age of 3, children with other diagnosed disabilities. The other law that protects children with disabilities is Section 504 of the Rehab Act of 1973. And this is basically a civil rights law that offers non-discrimination protection to children in schools that receive federal funding. Excuse me. So the federal government basically says disability is natural part of the human experience, and in no way diminishes the right of individuals to participate and or contribute to society. Improving the educational results of children with disabilities is an essential element of our national policy of ensuring equality of opportunity, full participation, independent living, and economic self-sufficiency for individuals with disabilities. This is what IDEA says, the Individuals with Disabilities Education Act. And Section 504 says that no otherwise qualified individual with a disability in the United States by the reason of his or her disability should be excluded from participation or denied the benefits of, or be subject to discrimination under any program or activity that receives federal financial assistance, and that includes public schools. And so we have 2 responsibilities to children with disabilities. One is to not discriminate against them, and the second one is to provide the special education services and supports they need to be successful and productive members of society. What we know is that COVID-19 impacted students with disabilities in many ways. The challenges that they already had, they were exacerbated. We saw an unprecedented level of isolation in students and their families. We saw a lot of regression in social and academic skills, particularly in their sense of belonging and their sense of welfare in the schools. And of course, it affected their sense of well-being, both at home and in schools. The most frequent issues that we see right now, post-COVID, in kids with disabilities, again, is self-mutilation, suicide risk, isolation, inappropriate sexual behaviors, a lot of harassment, hazing, a lot of behaviors that we're seeing in kids as young as kinder, 5 years of age, who are reproducing or playing in a very inappropriate way with their bodies, with their boundaries with other children. And in children who are more verbal, we see feelings of depression and separation anxiety. So these are some of the things. They do have implications, and so the fact that we have, I'm sorry, that we have children who have issues in the school setting means eventually that they will have decreased academic performance, that they will have a detriment in the feeling of well-being. They don't feel well, and they verbalize that they don't feel well. They don't feel they belong in the schools. They have poor coping. They get into fights. They get into arguments with each other. They have lack or limited social skills, and they also are at a higher risk of developing mental illness. And the things that did not help, remote learning didn't help students. As we know, they should be in school, but for students with disabilities, especially those who have autism, emotional disturbance, and things that are more severe, that being isolated, being on remote learning, being quarantined, and also keeping that social distance just did not help. And so right now we're having a big influx of referrals to special education or referrals to our school psychology team to address the challenges associated with post-COVID um, results. We have opportunities. There is some research out there that talks about what opportunities we have post-COVID to address the students' well-being. And so 5 key points: the ease of transition from remote learning to face-to-face. So encouraging students to be back. I'm not sure in India, but for example, in the United States, we already went back to face-to-face education, and most school districts um, also offer the parents a choice to keep their students at home with remote learning. We have a very small population of kids whose parents decided to keep them at home. We have to also consider the financial impact of COVID-19 in families. A lot of families lost their jobs, lost their ways of sustaining themselves and their kids. So we have a lot more requests to the federal government for support. The students' health or the students' families' health during the pandemic. Again, a lot of them lost the family members. Um, the feelings of belonging and engagement that we have a responsibility to increase, and also the overall success and wellness of the students. Those are opportunities that we have as members of a school psychology team to work with students. We do have a team of 5 school psychologists. And again, I am speaking from the angle and from the lens of a director of special education who has or who serves the needs of 800 plus students with disabilities. But we do have a team of 5 school psychologists, and what they have been doing to address the well-being of kids, especially post-COVID, is they've been working with them to build and to increase the resiliency. So that's one aspect that we all know is instrumental in child development. I am so sorry. I don't know what's happening to me. They also work to increase their self-determination and agency. So we want them to be agents of their own change. We want them to be decision makers of their own educational plans. So we support their ownership and of their education and their future. We constantly talk to them about them being their own agents of change. We foster adaptability. We constantly teach them that the world is always changing, that our families, our circumstances change, and that we must learn to adapt. We help them increase their social awareness of things around them, things in their family, in their community, things related to their own disabilities. And we help them increase coping and problem solving skills. And so this is something that it's both in the literature, but it's also best practice in the school setting. And so, like I said, we have a team of 5 school psychologists who work with students with and without disabilities in helping in these areas. Besides what the school psychologist team is doing, the school systems also have systems in place, or the school campuses overall. And so what we do as a school district, and this is a school district that serves close to 10,000 kids with and without disabilities, so it's a small school district compared to others. But one of the things we do is we embed social emotional learning in the curriculum. That's something that is new in Texas and in the United States. So the first few weeks of school, we teachers, campus staff, cafeteria workers, every staff member work alongside each other to help meet the students' emotional needs. That was the first thing. Then we have specific programs that we use for them. One such program is called Capturing Kids' Hearts, Positive Behavior, Wellbeing Supports, and Character Strong. We also help building the capacity of the school psychologists and the counselors. So we provided a lot of training for them in addressing the needs of students. There is also some allocation of funds. It's called the ESSER funds to address the students' needs post-COVID, academic and emotional. And there have been a lot of parent, teacher, and student training and supports group to, to help students. Again, students' well-being is our top priority. So we do understand that social and emotional well-being is a balanced, healthy way of interacting with others and is the ability to appropriately respond to our own emotions. It's a core aspect of anybody's development. And again, academic performance is largely dependent on meeting the students' basic needs, the physical, the emotional, the safety, the belonging, the love, the support, all the needs of the kids. There are some positive trends out there. One is increased access to inclusive experiences. On campuses, we do want kids with disabilities to interact as much as is appropriate with kids without disabilities. There is also a shift in the attitudes towards students with disabilities, and also there is an increased sense of self-advocacy in the student population, both with and without disabilities. And I would add that there is a push by parents who want their kids to be better self-advocates, and so they are constantly talking to them and teaching them how to be their own advocate. And there are a few best practices. There are many, but these are just a few. Teaching social and emotional competencies would help with well-being, creating multidisciplinary supports. In other words, having the teacher work with the school psychologist, with the parent, perhaps with a speech therapist in assisting the students, advocating for additional resources, getting social workers on board, getting additional staff, perhaps volunteers, and improving opportunities for socialization for students. So fostering those opportunities, creating events, including them in practices, in sports, in academia, in extracurricular activities, and so forth. So there are a few best practices that we do in the schools. And again, the well-being is our top priority. A little bit about our department. We are Sharyland ISD. We are a school district of approximately 10,000 students. I want to say 80% of our population is from Mexican American descent, 20% is a combination of white, Anglo-Americans, African Americans, Asians. Our population of Indian students is less than 1%, but we do have a few Indian families in our district. We in special education serve the needs of 824 students with disabilities. The most prevalent disabilities for us are learning, emotional, autism, and ADHD. And we do have a team of over 30 professionals who work with them. We have 5 school psychologists, 9 educational diagnosticians, 8 speech and occupational therapists, 7 teachers, including adaptive physical education, visual impairment, orientation and mobility, homebound teachers, and we also have 2 social workers. And these 824 kids are served through 57 special education teachers. So which means each teacher has a caseload of approximately 15 students. And this concludes my presentation. It is a short presentation, but I wanted to give some opportunity for discussion, questions, and feedback.
Thank you very much, Dr. Lela.
I have to apologize for coughing. It might be nervousness that I am presenting across the globe to an audience of academicians and experts. It might be that it's midnight and it's my sleep time. I don't really know what it is. I am usually not this one coughing, but I do apologize for the disruption.
We appreciate and we are grateful for your efforts, ma'am, because we acknowledge that it is a midnight time there, and your sleep hygiene and sleep routine is affected due to our program. But we sincerely we are thankful for that. And it was very nice deliberations from your side about the students' well-being, because we all in the academics, we all have to, because teaching and training is one part, and nowadays we have to focus on the well-being of the students. Unless and until they are mentally and physically fit, we cannot claim that we are doing our duties responsibly in teaching and training them. So thank you very much. Your deliberations will definitely be helpful.
Ajit, can I have a quick comment?
Sure, sir. Sure. Most welcome, sir.
Uh, Dr. Laila, it was a very wonderful presentation on well-being of children. Uh, just a small query. I don't know whether you can comment on it or not. There's a lot of problem of lead toxicity on American-Mexican border. So because of battery recycling and all that. So how it affects, you talked about the autistic children and all that. So how it affects the children, this lead toxicity, which is quite prevalent there.
So with the free trade treaty between Mexico, Canada, and the United States, what ended up happening is that on the Mexican end, as we all know, Canada and the United States are first world countries and Mexico is not. And so a lot of the factories and industries ended up on the Mexican side, right by the border. And that there was an increase in toxicity in the waters. There has been a lot of research on the effects of that, but I believe the results of the research have demonstrated that the most prevalent problem in children was hydrocephalia.
Okay.
So children who were born with
water retention in brain.
Water retention in the brain, that was one. There is definitely a huge increase in the population of autistic children. I cannot comment because I have not read enough research on whether it's lead toxicity what led to the increase of the autism population in the schools, but definitely in the district where I work, Sherryland ISD, our population of children with autism is very, very high.
Okay.
For us, for example, high, just to put you on perspective, we have 824 students with disabilities. And I want to say we have close to 200 students with autism, which is
quite a big
unheard of.
population.
Too many.
Too many.
1/4 of them, close to 1/4 of them have autism. So it is alarming. It is
Very
alarming, but I cannot link it to the lead.
Okay. I just wondered because I work on lead toxicity, so I was aware that because of the unorganized sector there, so much lead toxicity cases are reported from that part of the world. So thank you, and very interesting talk, and thank you for joining in the midnight. And your talk was very excellent and superb, and very lucid, and you elaborated things very nicely. Thank you very much.
Thank you.
Thank you.
Thank you very much.
Ma'am, may I ask a question? I'm sorry if I missed it in your presentation. So your talk actually helped me gain insight on how it would be for children who exist at the intersection of disability and lower income and come from lower income families. It comes from my experience working on ground during COVID. So children who came from the lower income families, they had so much difficulty attending online classes because in a family, if there are 4 or 5 children, there's just one phone. And they don't have any other way to attend the classes. And the mobile data hardly lasts them for 1 or 2 periods because 6-7 hours of mobile data, you don't get it here. So I only wonder what it would be like, especially for children with autism who may require one-to-one interaction, say in case of ABA training or, I'm sorry, ma'am, if I'm not able to put it across properly, but I just wonder what impact it would have on them.
So let me speak to the intersection between poverty or low socioeconomic status and as a result of the pandemic and disability. I think the issue here was a lot bigger than that. To begin with, what we can say, because we work in school districts that provided devices, electronic devices to families. And so if you have, for example, 3 or 5 children, the school district provided 3 or 5 laptops for the students to work at home. And if they did not have internet connection, we also provided a hotspot for them. And so their access to education was, yes, it was interrupted, but it wasn't as severely interrupted as in children in Mexico, for example. And I can attest to that. I am originally from Mexico, and I visited Mexico through COVID many times. And the problem you explained was very prevalent. We had children, 3 children in a family with only 1 phone. They couldn't access everything because they had to take turns. They couldn't connect to their teachers. It was just very difficult. I really think that the bigger issue and the bigger picture here is that in this region where I live, there is a lot of poverty. And the intersectionality between poverty and disability is that our families do not have access to health resources. They they do, but it's limited access. It's not the same access that a family with a better socioeconomic status would have in a different city. And so because we are so close with the border with Mexico, a lot of families end up traveling to Mexico on medical tourism trips. And that is both risky, it's good for a lot of families, but it's risky as well. And so the problem here, the bigger problem would be that kids don't have the same level of access to healthcare, education, promotion, services, resources, especially our kids with autism. And that is concerning. But it has to do with the geographical area where we live, and also with, I want to say, with the level of education of our parents as well, and the sense of advocacy that they do for their children with disabilities. I don't know if that answers your question.
Thank you, ma'am.
Partially.
Yeah, partially. Thank you so much, ma'am.
My email address is, let me put it on the chat, and maybe we can continue. I would love to continue this conversation. Let me put it in the chat.
Thank you so much, ma'am. That will be really helpful.
Ma'am, I have a question.
Yes, go ahead. If you don't mind reaching out to me, I would be more than happy to. Maybe we can meet over Zoom and talk.
Yes, yeah, thank you, ma'am. Ma'am, your deliberation is very nice.
Thank you.
Yes, ma'am. Ma'am, an example of Indian 14-year-old class 12th girl was set herself on fire just because her teacher scolded her on the academic performance in front of class. While these indeed are extreme cases coming across a highly sensitive child is not uncommon these days. How to come up with this problem? Because I am a teacher. So I am also handling the student. So sometimes strictness is also very important, but I think I observe the students take in a very negative way. What should do? These cases are increasing day by day, and this is, I think, is a very negative thing. So, ma'am, you are expert on this, especially in the context of children's. So, what's your suggestion, ma'am?
We see that problem here too. The example of not exactly of a child setting a classroom on fire or something like that, but what we see is a lot of terroristic threats. So when that happens, we have 2 courses of action. Let's say a child was scolded or was bullied, or something happened between the student and a classmate. And the student is angry and decides to do something about it. And that doing something is either threatening to, in the United States, is very common, for example, to shoot the school, to bring a gun to school, or to hurt a group of people in the school. We have 2 courses of action. One, the student has a disability. The way we discipline the students with disabilities is by looking at the link between their disability and the action or the threat or the behavior. And so if we find that the student has for example, an emotional disturbance, and that emotional disturbance is linked or is in direct relationship to the behavior, which was threatening another person or threatening the school, then we cannot suspend the students. By law, we are not allowed to suspend them or change their placement to a more restrictive environment. But if the student doesn't have a disability and commits such an act, then we can discipline the student in a way that any other student would be disciplined, by separating them of the campus, by putting or placing them in a disciplinary alternative education program, which we have. And in that program, the student receives intensive interventions and supports so that the behavior doesn't happen again. If the student has a disability, then we immediately place a social worker and a school psychologist to work with that student so that we address the behavior and that it doesn't become a more severe issue. And so again, if a student does that, we have two courses of action. If the student has a disability, there is a team who works with them from the special education office. If they don't, change of placement, immediate removal from the classroom and the campus to prevent more issues from happening, but also a team of people who work with them in a separate environment.
Okay, ma'am. Thank you, ma'am. Thank you.
Thank you so much, ma'am. Thank you for such an elaborate discussion. The presentation was really insightful, and not just that, thank you for your patience in sparing your time at such hours of the night. We'll be happy.
Thank you very much.
We'll be happier to remain connected with you, ma'am. So really, thank you so much.
Thank you.
Thank you, ma'am. We'll be moving to our next speaker of the day, Professor Dr. Raza Amir. Professor Dr. Raza Amir is Professor of Management at Cotsacos College of Business, William Patterson University in New Jersey. He did his PhD in Strategic Management from University of Massachusetts and PGDM from Indian Institute of Management, India. He has received the William Patterson University Award for Outstanding Scholarship in May 2008 and Beta Gamma Sigma Award for Best Teacher, School of Business Administration, Monmouth University in 2001. Professor Mir is currently the Editor-in-Chief of organization. He was Editor Journal of Business Ethics and Associate Editor, Qualitative Research in Organization and Management. He also held the position of Division Chair, Critical Management Studies, Division of Academic Management. With this, I would like to extend my warm welcome to Professor Raza Amir, and I would request her to take over the platform from here on.
Thank you. Thank you very much for that most generous introduction. And I do realize that we are running slightly late, so I will do my best to give back some of the time. And if you don't mind, I will share my screen with you. And sure. What I would do is that rather than speak impersonally, I would talk about my own personal experiences in the healthcare sector. And primarily, this is in the pharmaceutical industry. I had a wonderful time listening to the past 4 speakers, and I learned a lot from them. But I do realize that my presentation is quite different from theirs in the sense that this is more from the economic side and from the industry side. So if you have more interest, you can always reach out to me, but I will proceed as quickly as possible so that we go through this and maybe give some time back to the other speakers. Now, in the pharmaceutical sector, which is a very important element of the healthcare industry, as you know, extended the life of humanity over the past several decades, and in fact, a couple of centuries. India has played a very significant role, not only in producing domestic benefits, but also as a international player. But before I go into the sector, I just want to briefly talk about a couple of theories that most of you are reasonably well aware of. As far as the idea of the intersection between economics and industry is concerned, two competing hypotheses emerged primarily in the 1980s. The first is the idea of an inevitable globalization, that it does not matter where you live, it does not matter where you produce, it does not matter where you sell, because globalization will equalize and create a borderless world, a flat world. This person whose name I have put there, Kenichi Omae, he was the CEO of McKinsey Corporation, and he put forward this thesis quite clearly in that book, The Borderless World. The second hypothesis was that globalization is really not that much of a force, because the importance of location and the importance of where you live, where you make stuff, where you sell stuff, continues to remain salient. So I'll first talk about the first idea of globalization. Now, globalization is a very old idea. We in India, for example, in our cuisine, we always use tomatoes. And we would like to think that tomatoes are native to India, but actually they emerged from Mexico and they reached India several centuries ago. So you could say that cuisine, and through the spice route and the silk route and other things, there was always globalization. But after World War II, what really happened was that the globalization began to intensify, and it really was based on this idea of comparative advantage, which is that if you make something well, then you should do only that stuff. You should only do things that you are good at, because the things that you are not good at, you can always trade your way and get maximum efficiencies out of it. That was the idea of globalization of production. The second idea is the globalization of markets, that if you make something well, then you can sell it all over the world, and we will find ways to send it across national boundaries and make things happen. And the last thing is the coordinating power of global and multilateral institutions. After 1945, after the Second World War, a variety of institutions emerged that made this globalization possible, that lubricated it, that made it frictionless. And so there was the World Bank and the IMF and the World Trade Organization. All these impacted the pharmaceutical and healthcare industry substantially. Now, the other idea that I was talking about is that everybody is not good at everything. They say that the best, for example, leather products come from Italy. The best automobiles come either from the United States or Japan or Germany. And these things have remained relatively constant across the years. For example, in the movie industry, you have Hollywood in Southern California, which is really a very important hub. And then India, of course. I'm sorry. So the idea is that there's always national advantages that are there. And India really became a very important hub for the international production of pharmaceuticals, particularly in the 70s and the 80s, for all these four reasons, which is that there were factors of production. India had huge scale facilities where they could manufacture and distribute drugs all over the world. They had demand conditions, which means that they had a lot of patients in India that were using Indian products and improving them by giving feedback to companies. They were related and supporting industries, which meant that, when you want to manufacture pharmaceuticals, you need to have certain kinds of equipment and certain kinds of excipients and other chemicals, and India manufactured that too. And finally, there is domestic rivalry, which is to say that India had a large number of pharmaceutical firms which competed with each other, and in the process of competing with each other, made each other better. So we were wondering how this process would continue in the pharmaceutical sector in India. So I don't want to spend too much time talking about my own personal journey, because that is one place where I can save a little bit of time. But I want to say that in the late 80s and the early 90s, I worked in the pharmaceutical sector, and I saw how the sector was responding to a variety of global challenges. And then after that, after I worked for a little while, I went for my PhD. And during my PhD, I did my research in the pharmaceutical sector and learned a lot about it. Now, in 1991 in India, large amounts of economic liberalization happened. And as a result of that, foreign capital began to come into India. But more importantly, the intellectual property regime began to get tightened. I'll speak a little bit about that and how it really affected the Indian pharmaceutical industry and the healthcare sector in general. And finally, fast forwarding to the last couple of years, of course, I spent a lot of time studying how the vaccine regime emerged and how different parts of the world responded to all kinds of constraints with regard to production and the availability of vaccines. So moving along, like I said, I joined the pharmaceutical sector in the late 1980s. At that point in time, India was not a signatory to several of the intellectual property regimes. There was this so-called Paris Accord, which was there, which prevented companies in certain countries from manufacturing products if they were patented in other countries. India was not a signatory to the Paris Accord. As a result of that, the Indian pharmaceutical firms were able to take brand new pharmaceutical products, reverse engineer them, manufacture them in bulk, and sell them cheaply. The price of pharmaceuticals was low, and India was not just a producer and consumer of pharmaceuticals, but it was also a net exporter to different parts of the world. But then what happened was that in the 1990s, as the Indian market began to liberalize, India signed several of the intellectual property protocols that were mandated by the World Trade Organization. And so this business of reverse engineering drugs and selling them slowly began to halt. And India had to transform, and they became more of a sort of a client industry, in the sense that the drugs would be innovated in other parts of the world, like the United States, and those companies would then use India as a manufacturing hub and send things over. Pharmaceutical products became a little more expensive as a result of that, and then the access to particularly innovative pharmaceutical product became very, very unequal all over the world, but also here. One of the biggest crises that happened in the late 1990s and in the early 21st century is the AIDS crisis, for example, in Africa. All the AIDS drugs were the retrovirals that were needed to combat AIDS were patented by large American and European companies who refused to release the patent. Hundreds of thousands of people died because they did not have access to these drugs. And the tragedy of it is that, I mean, they couldn't afford it because the price of those drugs was more than what their income sometimes. The tragedy of it is that if they had given the drugs cheaply, it wouldn't really have affected their markets. As a result of that, certain companies in India actually took the lead and said, hell with the patent regime, we are going to break the patent law and we are going to provide drugs cheaply to Africa. And if you want, you can take us to court. And that would have been a public relations disaster for them. So fortunately, low-cost anti-AIDS treatment began to be made available to Africa through these Indian companies. And currently, we are seeing the exact same scenario work itself in different parts of the world. The mRNA vaccines, particularly the ones manufactured by two companies, US-based companies, Pfizer and Moderna, are very effective against COVID-19, but they are not being made available to large parts of the world, as a result of which, there are surplus stocks of mRNA vaccines in the United States and complete inability elsewhere, with India, of course, lying somewhere in the middle. So, like I said, the Paris Convention was not signed by India. It's a 19th century agreement. And the fact that India was not a signatory to that really helped them for decades and decades. But in 1994, 1995, India began to get pulled into the intellectual property ambit. As a result of that, they really could not reverse engineer drugs anymore. And so the pharmaceutical industry has had to retool as a result of that. So just to quickly move ahead, I'll come here. Now, what is happening right now is a very, very interesting and a tricky idea. The mRNA, the idea of mRNA vaccine is really a certain kind of delivery of antibodies to the system that has been perfected by these couple of companies who are not really interested in sharing these ideas with the rest of the world. Now, so the developing world, companies in Brazil, companies in South Korea a little bit, couple of them in Thailand, and a few companies in India are really at the forefront of trying to create, I should say, a new kind of an mRNA vaccine that would really get past the Pfizer and Moderna patents. And we really look forward to that developing. But what is needed in the current environment for a company in a country to succeed is these four things, right? First, there should be existing facilities. And again, here India has a little bit of advantage. There are three companies, Serum Institute of India, Biological Events, and Genova Pharmaceuticals, that are developing the new technology needed to produce an indigenous and a non-patented mRNA vaccine. Then you also need a lot of human capital. You need trained personnel in this area. You need people who are experienced in the pharmaceutical sectors, in pharmacokinetics, and in delivery systems. And again, there, India has the ability to push through into that. You need a regulatory system for medicines. You need to make sure that drugs that are manufactured, these vaccines are, after all, going to be given to vulnerable populations, that they have the requisite amount of purity, that they have the requisite potency, that they are testable, that you can have human trials, and that there is a government body that looks at them and makes sure that it happens. The general perception is that while India has that system in place, it is relatively weak and not as well implemented as is needed for such an important scale level operation. And finally, you need the political, economic climate. You need the political will to invest in this and to make sure to coordinate between firms that might be perceived as competing with each other, telling them what to do, making sure that knowledge is shared, and making sure that the drug is produced as quickly as possible. And that too is reasonably available in India. And so all I have to say here is that the experience, if you divide it into these three phases, the first phase where there was reverse engineering, the second phase that there is manufacturing, and the third phase, which is the key phase, where actually through the indigenous innovations, you are actually able to make a huge intervention in the global healthcare sector, makes India one of the most promising places in which to change the paradigm of healthcare for times to come. And I thank you very much for your attention, and I will, be happy to share more information if you need, and look forward to hearing from the rest of the speakers.
Thank you so much, sir. It was a really insightful presentation on the role of pharmaceuticals, and you have given us great information on how the pharmaceutical industry has developed over a course of years. And not just that, it has been significant to understand what is the importance of pharmaceutical industry in the healthcare sector, it being one of the most important and most dominant area whenever we talk about healthcare sector. So thank you so much, sir, for that information.
Thank you very much, sir. I am aware that it is, I think, around midnight or something, and you are still awake for us. So just heartful gratitude from our side, sir. And you have always accepted our invitation and very appreciated our sincere efforts as well. So looking forward to more such associations, sir. And please stay connected and please take care of your health as well.
Thank you very much. And it was very useful. And I look forward to keeping on hearing from the rest of the speakers. Good night.
Thank you very much, sir. Thank you.
We'll be moving to our next speaker, but before that, just a very small announcement for the participants. Since we are running a little behind time, it is just to inform you that the technical sessions that are supposed to happen at 1:30 will be beginning at 1:30. So whoever have their slots in the beginning can leave from the lectures during that time. But we'll be continuing the lectures and we'll be proceeding as they are going right now. So with that, I would want to extend my welcome to our next respected guest, Dr. Anna Rosengren. Again, I would want to extend my apologies if I mispronounce the name in any way. So Dr. Anna Rosengren is the founder of Global National Happiness Sweden GNH Leadership. GNH Sweden is a growing network developing Sweden standards for the value of GNH, gross international happiness, which is a method for measuring and cultivating abundance and welfare, is a more holistic way than merely living standard. So with this, I would want to extend my warm welcome to Dr. Anna and would request her to share her views on the present topic. Over to you, ma'am.
Thank you so much for the introduction. And let's see if I can share my screen now with you. So, I do hope you all get some pause in between also, that you can bring a cup of tea or whatever you need. I guess I have like 20 minutes or so. Is that correct?
Yes, ma'am.
Yeah, and
yes,
then maybe have some dialogue or something if you wish.
Definitely.
So please let me know also if there is any question during the presentation, if you want to clarify something. So yes, like you said, you can say I'm a researcher as well as a theologian and a priest, and I'm also activist in global well-being. And why is that? Because I think it's so important that we feel well in our lives, both individually and together. What else could be more interesting or important than to feel well? So I'm going to talk about how to promote happiness and well-being post-COVID-19, how to cherish and cultivate our happiness and well-being now. And yeah, this is me. Like I said, if you want to contact me, I'm most happy to have contact with you all. So let's connect to each other. As you can see, I really love pine trees. We have lots of pine trees in our garden, so you don't always have to go so far to connect to nature, to yourself, or to others. So I'm going to share with you what I believe are our post-COVID-19 wounds, very briefly. And then I'm going to mainly talk about one path to healing, one possible path. There are so many paths, but one possible path. And then maybe we can have some dialogue. And these, as you can see, are birch trees, very common in Sweden. Yeah. My first question to you, which you, if you like, you can answer in the chat box. I will not be able to start a dialogue around it now, unfortunately, but I'm very interested in how are you now, post-pandemics? I mean, we are often talking like intellectually about this, but what about your life, your heart, your soul? How are you, really? Behind the face mask. Just reflect for a while, for 1 second for yourself. How are you really? What has changed? Where are your wounds, your learnings? We are all somebody behind the mask, right? So how are you behind the mask? I believe that we all have at least 1 or 2 wounds that we need to heal now after the pandemic. And these wounds, that they can be placed in different parts of our individual and collective, what can I call it? Body, soul, and mind. It could be about, I mean, economics maybe. Maybe your economy has gone down so that you have difficulties in supporting yourself and your family now. Maybe businesses are not so much running anymore for a while, and it's difficult to get a grip on it again. Maybe it's your physical health mainly that has suffered, or maybe you have lost someone you care for. Maybe you have been worried about your health or others' health. Maybe it's about leadership and governance. Maybe you have been worried about how to organize your life, or how society is organized now, how to trust it. Are there trustworthy structures like that now? And maybe you have been wounded in your participation in society, that you have been worried about how to take part in society change and how to transform everything now, how to contribute. Maybe it's your inner well-being that's suffering. Maybe you feel like unbalanced or worried, or that you lost hope somehow. Maybe it's the time use, how to use time now, how to focus, what becomes important suddenly. Maybe other things become important suddenly. Maybe you need to prioritize in a different way. How has that been for you? Or maybe it is about cultural diversity. Maybe it's difficult in society and for you to be different now. How has that been affected? Are we allowed to be different in the same way, or is it more difficult in this kind of crisis for different groups, for different parts of you to be expressed? Or maybe it has to do with, of course, our relation to nature, our possibility to be close to nature and to care for nature. Maybe that has been prioritized or put aside. Maybe it's about education or development. It could be different for us. Why I'm showing this is because it's also connected to how we are as a global community. I believe that your well-being and my well-being is connected very much to our global well-being. How are we post-pandemics? I mean, are we like drowning in our own, initiatives for global well-being, or is it coming forth? Is it like we have learned something now? What's happening to us globally? I really believe that we have three main wounds, both individually and globally. It's like as if it's opening up, cracking up these wounds. This pandemic is opening up our wounds in such a way that we cannot ignore them anymore. It's not possible to neglect it anymore. It's all too obvious that our ecological wounds are painful. Nature is aching. And we are kind of getting disconnected to nature. We don't no longer feel the connection to nature, which we normally should. We are earthlings or not. We are not from another planet or something. We just landed on this one. We are also earthlings. We are sprung out of this planet. And there are social wounds. We don't even reach out for each other, maybe. Maybe we don't trust each other anymore. Maybe there are some issues about groups turning against each other, like this bullying we heard of earlier. And maybe these things are increasing in a sense. There are existential wounds, so that we also maybe don't connect to our deeper selves, that we have forgotten our souls. Who are we and where are we here and what is important? And are we even worthy of survival? So these things, I guess they have become more acute now, in a sense that could feel negative, but it's also positive in the sense that when we become aware of it, we can also do something about it in a new way. We have a chance for a transformation now that we never had before. So now at last we can kind of heal. We have a chance to heal deeply from our, what I call, global self-harm. You know, in programs like Alcoholics Anonymous and similar programs, you know, for drug abusers and alcoholics. I work a lot as a priest. I work a lot in the prison, and I also work a lot with people with drug abuse and alcoholism and similar things. And I can see and I understand that there is a kind of self-harm growing up. Many people have also worsened their situation now during COVID with their abuse of different kinds. But I also think that there is something I would like to call the global self-harm. We also have a global self-harming behavior. We are kind of cutting off the branch we are sitting on. And why are we doing this? We need to recover. We need to at least understand that this is important for us also together. So to do that, I believe this is possible, still possible. It's not I mean, it's not too late yet. It's always possible. And to do that, I believe that three things could be important right now. One thing is to restore balance between all these things that I showed you before, these different aspects. Another thing is to transform our mindsets, transform deeply on all levels, so that we no longer even reflect on our situation in the same way. It's a question of deep transformation, and yeah, you can call it enlightenment if you like, but it's more of a practical transformation also. It's about existential recovery in the sense that we need to focus on truth. We cannot hide and deny anymore. And we need to recover in the sense that we see the truth for what it is, individually and collectively. We also need to develop trust and hope. There is hope. Like Albert Einstein, he said, you cannot solve the problems with the current situation with the same level of thinking that created them. So we need, of course, a mind shift. And this is nothing new, I guess, to all of you. We really need a mind shift. So how to do this mind shift? Well, I believe that first of all, we need to see that it's not only about behavior or thoughts. It's not even about only feelings or even about values only, even though values are much deeper than feelings, of course. As you can see, this is a kind of a lotus pond. It's about mindsets, and that's much deeper. And to shift our mindsets, we really need to go into the individual realm, your inside, your personal inside, as well as your personal outside, the behaviors that we have individually, and what we are doing in our lives, our concrete projects and whatever we are contributing with. We need also to go to the culture, to the collective aspect, where we develop different norms and where we together cultivate our view of what's happening. And of course, we need to change the system. But we need all these things. We need to change all these 4 areas, and they need to be integrated, because only then there could be lasting change and healing. And I believe this is part of the mindset shift that we need to do now. This model is from Ken Wilber, and I guess many of you have seen it before. One can say that a mindset shift, both for an individual and a collective, is about shifting our view so that we, you can say, raise our awareness into a new level of living and being. It's as if you are on different levels in a kind of a high storage house. And when you shift from one level to the other, it's about all these 4 levels, 4 arenas that I spoke about earlier. They are integrated. And when they are integrated, then we can lift it to the next level. So what level is relevant around you just now? How are you speaking and talking to each other where you are? Is it about survival mode? Or is it about magic worldviews? Or is it about trying to take what is yours before somebody else takes it? Is it about competition like that? It can easily happen that we back into these kind of levels when crises happen to us. This can happen individually and this can happen collectively. Is it about traditions, law and order, doing what is right? Or is it about results and efficiency, branding? That now, please take the chance to become more efficient in your branding or your own particular projects. Is it about values and trust, relationships and being authentic? Or is it about integrating all these things, seeking meaning and hope? Or is it even more complex, like kind of a holistic self-organization, or even acting as the emerging new reality? I mean, these are different levels of awareness, and they're all relevant in one place or the other. It's relevant in a place that is, dealing with survival, to focus on survival. But it's also relevant in another place, which is focusing on business development, to focus on that. So what we need is more people who can be flexible in this system and who can move up and down in this high storage house, as I would like to call it, who can be flexible and integrative. So what is needed around you, and how flexible can you be? Can you incorporate all these different levels? Where are you? I believe, as I said, that healing factors are to restore balance, to transform mindsets, and to recover existentially. And I want to tell you, as a way of finishing up a little bit, about a program that we are starting now, and it's about exactly these three factors. Because we thought, let's do it together. Let's not just talk about this, let's do it, and let's do it together in different hubs, in different places of the world. Let's connect now. And this is our suggestion of how to do that. We made a healing program, and that is for 1 year, and where we are going to try now to reconnect to ourselves, to each other, and to nature through these three building blocks. One is GNH, and that's what I showed you initially. I'm going to show it again soon. GNH, gross national happiness from Bhutan, is the way of restoring balance between different aspects of life, instead of only measuring gross national product or only focusing on like economy or production or consumption, which is also important, but to also involve other aspects of life, quality and well-being. And then there is the theory U, which is about transformation. It's a method for deep transformation in society and for you yourself. And then also, thirdly, it's about the 12-step program, which is the program for Alcoholics Anonymous and drug abusers, like I told you. But this is slightly adjusted so that it would fit to our global situation just now, and also address our global self-harm. So you can say it's a 12-step program for global well-being, building on these three things. And the first, I'm going to show it again now then, GNH, gross national happiness, or in our Swedish version, we call it global natural harmony. Why? Because we have adjusted it a bit. We are not using it in exactly the same way as in Bhutan, but with more focus on, for example, cultural diversity, so that you don't need to be or become anything special in a religious sense of the word or in the cultural sense of the word. You can be whatever you want to be, but just develop the diversity and your own existential identity. But the most important thing with this model and method is that to develop balance between these things. And if you are interested, I can send you, if you mail me or if you ask me in the chat, I can send you an index and a test, you can say, so that you can start reflecting on your own balance in these 9 dimensions. How is your own balance? And then it's of course possible to check the balance of your organization or your society or your nation even. But I'm going to share with you the individual index if you like. So you can reflect upon that more. This is one part of our program. And then the theory U, like I said, it's a model that has to do with transformation. And it's involving transformation not only of the mind intellectually, but it's also involving your heart, your relations, your feelings. And most importantly, maybe, it's involving your will, your deepest sense of being. So bringing in all these 3 things, this model will kind of crack up everything that you took for granted. It will bring in your work life as well as your private relations and your self-image and whatever you are in, society and neighborhood. And you will get the chance to reflect on what is dying now in your life, collectively, socially, globally, What is dying? And what needs to be dying? What needs to be let go of? And what is being born? What is new that is being born now? So this, as you can see, is a deep, deep process of life and death. And then, as I said, the third building block in our program, our recovery program, is the 12-step program, which is about openness and honesty, but also about hope. It's 12 steps that will restore yours and mine existential health and well-being. Back to truth, back to faith and hope. Let's just give up our old ways. It's no use to do more of what is not working. That's the definition of abuse, actually, of alcoholism or drug abuse or any kind of global self-harm. The definition is to do more and more of what is not working. So let's just surrender. There's a deep self-examination also included in this, much deeper than the one I mentioned just now before. And then one works with humility and restitution and spiritual growth, so as to become to service for the whole humanity. And it's also about bringing in whatever you are caring about just now. So bringing that into the equation, not just doing this as a program that is separated from your life, but bring your life into it. Bring your life into it and plant it into this program. And then some kind of magic will happen, we guess, we hope. That's what we are going to cultivate at least. So thank you for that. This is my small contribution just now. And if you have some questions, I'm very much happy to continue with a kind of a dialogue, if you like. I see some people have written in the chat here. Yes, so many people have written here. Some people say that they feel stressed and exhausted. New things have to come. Kind of disoriented, fine, confused. Different kinds of reflections on how we feel. So I guess I was correct in guessing that we are not always feeling completely well after this crisis. Somebody asks here, Anna, why did you leave out the good governance from 9 dimensions? Yeah, good governance, I think I mentioned it, that we need to sometimes reflect on how are we governing our lives, organizing our lives, how are we trusting our local or national governments or leadership structures now. Maybe there is not always trust there. So I think I mentioned it. This data is intensive, somebody said. I don't know what you meant about that. Please, D. Patnaik, if you want to clarify your question. Somebody is asking also, things were taken for granted before COVID, but now we need to face them. Yes, I believe you're right. Somebody wants to look into that index. Yes, we will send it. And how can we use the Swedish concept of lagom into this? You know, the Swedish concept of lagom, that is just enough. Yeah, so it's from, you know, when the Vikings were supposed to share the drinks around the whole team, then they could not drink too much and not too little. So they drank just lagom. So it would be enough for the lag, the team. That's it. So why not introduce that term? That's a good idea. When is it enough with growth on the cost of the planet? So maybe lagom. In empirical work, we test data, right? Then we use statistical techniques. Yeah. right? Is there any other question? Please feel free to ask. For example, the Patnik, if you had something more to say about this with data, there was something you wanted to ask.
Dr. Anna, I think we have pretty much covered all the queries of our participants. And thank you so much for such an informative presentation, especially regarding the impact of COVID-19. And we are still in a phase where we are trying to understand what are the after effects of the whole COVID-19 situation globally. And not just the COVID-19, but even the post-COVID implications which have happened with the people who have suffered COVID-19 situation. So thank you so much. And also thank you for telling us the importance of why is it important for us to know the level of awareness and what are different levels of awareness. So
Yeah.
thank you so much, Dr. Anna. And it was
Thank
a
you
very...
so much. Can I just clarify this last thing, because I got now a more proper definition of the question. Yes, the definitions of these 9 dimensions in GNH, they might be slightly different in my presentation for 2 reasons. One is that I chose to focus on the individual level a little bit more, which is our specialty actually. GNH of Bhutan is made for a nation only, mainly. And for the second reason, because our model, Swedish GNH model, is also slightly different and has different definitions like that. But we also cover, of course, the structures and the institutions and the political governance and misgovernance. That is also included, but not in these 20 minutes. But thank you so much. And my address is in the chat, and please contact me if you like. Thank you.
Thank you, ma'am. Dr. Abul Hussain, I would request if you want to say a few words. I can see your responses in the chat section. All right.
I think.
Yes, sir.
I think I didn't get the questions that my ill fate, in fact. When you are getting a lot of questions, then it's very easier to get something new to know. Anyway, 2 comments I got. Those 2 comments are very much, they praised my presentation. So thanks a lot, I think. Do you think any other questions for me?
I don't think so, sir. The questions we've seen were more related to the previous presentation. So thank you so much, sir.
Okay, thank you. Thank you.
Right. We'll be moving to our next speaker for the day, with Dr. Sufia Talib. Dr. Sufia Talib is a medical officer at Department of Health, Uttar Pradesh government. Prior to this, she has worked in Department of Emergency Medicine, King George Medical University, Lucknow. Extensive experience in the field and has served as junior resident urology department at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. I would hand over the platform to Dr. Sufia and would request to start with her presentation.
Dr. Shubia Talib, we are not hearing.
Okay, good afternoon, everyone.
Okay.
Good afternoon, everyone. Am I audible now?
Yes,
Am
yes.
I?
No.
Okay, thank you. Thank you. I'm Dr. Sufia Talib. I'm here to discuss the topic which most of the time go undiagnosed or undiscussed, but it is one of the topic which has major influences in our life, and we encounter it day to day. But somehow this condition it almost go undiagnosed or unspecified. Now the postpartum blues, it is basically a cluster of psychological condition which a mother she faces immediately after giving birth or immediately after undergoing an abortion. Now I am going to start my presentation with the first case is fictional. Can we move up the presentation? Next slide, please. Can we go to the next slide, please? Okay, thank you. Now, my case number one is a fictional case. All of you must have seen a Shutter Island movie. In this, there is a character named Dolores Chanel, and she was the protagonist of The Wife, Teddy, Leonardo DiCaprio. And the wife, the Dolores Chanel, she was accused of drowning all of her 3 children who died. And she was accused of infanticide. And afterwards, he murdered her wife. So in that movie, this character, the Dolores Chanel, she was suffering from depressive disorder. It can be a postpartum depressive disorder. Now, if you are thinking that such kind of incidents are shown only in movies and they only occur in movies, then you are absolutely wrong. I have a next case which is a factual case. Next slide, please. Please can change the slide. Next slide. Okay, the next case is the factual case. It was reported in July 2006. 2 inmates of the same jail. Actually, it was not a jail. It was a psychiatric center located in Texas. 2 females named Andrea Yates and Dana Schlosser. Both of them are accused of infanticide, and both of them killed their own children. Andrea killed all of her 5 children, and Dana Schlosser cut hand of her 11-month-old of her daughter, and both are accused of homicide. Now, both of them are suffering from postpartum psychosis. Andrea Yates has a long history of psychosis for which she was taking care from a psychiatrist, but the disease progressed and it resulted in that she has murdered all of his 5 children. Now, this kind of disorders which both of these females are suffering from, it started from a range. It started from a range of illness which can be mild, can be moderate. In some instances, it can be severe. It includes the three main categories of psychological illness, mainly puerperal blues, the postpartum depression, and postpartum psychosis. The first being the most common, the puerperal blues, it is most common, and the least common one is postpartum psychosis. But the cases which are diagnosed in more number are postpartum psychosis because it has severity of illness. Earlier it was thought that such kind of psychological problem have high incidence in developing countries like India, but new studies suggest that it had equal incidences both in developing countries like India and developed nations like USA and UK. The main reason for developing of such kind of psychological problem in a new mother, or you can say females, are most of the reasons. The first reason is the hormonal reason. There are many hormonal changes when a female undergo pregnancy, which directly or indirectly affect the psychological behavior of the female. Secondly, new roles which she has to interact with. She is a new mother. She has a lot of stress. She cannot decide what to do, what not to do. She does not have experience of being a mother beforehand. All these factors contribute to such condition. Plus the body shaming. She has gained weight. She does not look. She thinks does not look beautiful as she used to think. So such factors and the stress condition, they contribute to such condition. Now the milder form is puerperal blue. It is the most milder form of this disease, and the incidence is as high as 25 to 50%. All 25 to 50% of the new mothers suffer from this puerperal blue. The most common feature in this condition is mild depression to irritability, which includes detachment from the newborn child, or she does not like to sleep, insomnia, she does not like to eat. The time of onset of this disease is usually from 3 to 7 days. It usually do not occur before third postpartum day. It really occurs after 3 days and up to 7 days, and it gradually pass off within few days. The main cause behind this can be explained the lower tryptophan levels, because as the mother give birth, the hormonal levels of mother, they fall rapidly. So it causes decrease in tryptophan, which leads to decrease in the neurotransmitter, which ultimately lead to this depression, irritability, detachment kind of. This kind of condition, it does not require any specific treatment. Only we can reassure the patient and psychological support such as support from family, from elders in the family, from the husband, from nurses, from anyone who is helping the mother with a newborn child, and reassurance that she can do better. It happens with everyone. Like the words like that, they can helpful for the mother to overcome such kind of puerperal blues. Now the milder form of disease, it is a moderate form of disease, the postpartum depression. Incidence is as high as 10 to 20% of mother, and it gradual in onset. It starts gradually after mother gave birth or after an abortion, and it reaches its peak level in 4 to 6 months. It is due to changes in hypothalamic, pituitary, and adrenal axis, mainly due to hormonal changes. Pituitary is it's the guiding factor between the hormones which release from the adrenal axis and our sex organ like ovaries, like uterus. Due to changes in such kind of hormones, there are changes in neurotransmitters, there is changes in mood of the patient, and it leads to depression. The most important thing, apart from the features of puerperal blues, which are insomnia, irritability, depression, suicidal attitude is present in this postpartum depression, because mother think that she is not good for a child, or she cannot do any good, and she is depressed, she cannot take care of her child. So she thinks of doing suicide. Suicidal attitude is present in this kind of psychological condition. Now, high risk of reoccurrence. The high risk of reoccurrence is as high as 50 to 100% of all the patients. They have risk of developing depression in later part of their life, or developing postpartum depression in their later pregnancies, as associated with all the other metabolic diseases which a mother encountered in pregnancy, like gestational diabetes. She has risk of developing it in later part of the life. Treatment in this include SSRI, selective serotonin reuptake inhibitors. Mainly, they act by increasing the extracellular concentration of serotonin, which elevate the patient moods and which overcome by depression, and plus the estrogen patch. The estrogen patch is mainly to overcome the hormonal disturbances or the hormonal irregularities with which a mother is going. The prognosis of this psychological factor is good, postpartum depression. Now the third, it is the most severe kind of psychological problem which the mother face, and it is postpartum depression. It is postpartum psychosis or postpartum. Earlier it was called postpartum schizophrenia. Now it is called postpartum psychosis. Incidence is as high as 2 in per thousands of deliveries. Means if 1,000 mothers have delivered babies, then 2 of them will be suffering from postpartum psychosis. Onset is relatively sudden. Sudden means a mother, she is fine today and she will not be fine the next day. This include very severe symptoms such as hallucination, delusions, insomnia, depression, mood irritability, mood swings, and delirium. Although the delirium is rare kind of symptom, but it do present in this. Suicidal infanticidal impulses may be present, which is harmful for the baby. The mother thinks that all this which is happening to me, it is because of this newborn baby, so I should kill this baby and I will be fine. So it leads to suicidal and infanticidal impulses. Plus, the newborn child, he cannot oppose a mother, so it leads to infanticide in such kinds of postpartum psychosis. It also have risk of reoccurrence, which is not as high as it occurs in postpartum depression, but it is also 10 to 20%. 10 to 20% of the patients who are suffering from postpartum psychosis are at risk of developing them in their later part of their pregnancies, but they may also develop bipolar disorder in their future life, or they may also develop schizophrenia in their later life. The most important thing is that here, that a patient who developed postpartum psychosis is somehow, maybe she has developed postpartum psychosis is in her earlier pregnancies, or she is having a family history of developing psychosis of schizophrenia. Treatment in this, it involve antipsychotic drugs such as clomazepine, fluoxetine, and we can give estradiol sublingual. All these drugs are safe for lactation also because they do not secrete in breast milk, so you can give them. ECT if the patient is unresponsive to drugs. If a patient is unresponsive to antipsychotic drugs, then we can consider for ECT, electroconvulsive therapy. And we can also use lithium as a mood stabilizing agent. But the only drawback with lithium is we have to stop breastfeeding of the mother, because lithium, it can pass into breast milk, and if a baby consumes such breast milk, he can develop lithium toxicity, which can be fatal for the baby. Now, secondly, what are the psychological response to perinatal death? A psychological response to perinatal death is response of the mother to her infant death. It can occur after an unexpected hysterectomy. For example, if a mother, she's going to deliver a baby and there's some complication during the delivery, or she is having placenta previa or any other such disorder, when it is very important to remove her uterus for sake of the mother, then it is a major blow to her psychological condition, because she was not expecting that. Maybe she is planning to have further babies, but she cannot have because of the hysterectomy. So the psychological response is very intense. Now, second, the birth of malformed or critically ill infant. Mothers of such malformed or critically ill infant develop this kind of condition because they are not very close to their newborn child. They are apart. They are a distance between two. The critically ill infant will be in an ICU and a mother will be outside. She cannot hug her baby. She cannot be close with her baby. She cannot breastfeed her baby. So such kind of condition led to development of psychological disorders in pregnancy. Now that the most important treatment or most important management of such psychological condition is psychosocial support from the family, support from husband, support from the elders of the family, support from the hospital staff, and support from anyone who is taking care of the child. We have to reassure the mother that everything will be fine, your baby will be with you, or everything, you will have a good life ahead, your baby will be fine, and this is how the pregnancy ends up, you will be a good mother. Such kind of words, it can lead to a good response from the mother. One another important topic which somehow is you can say is not much related to this, but somehow can be related to this, is syndrome de Silverman. You all be knowing it by battered baby syndrome. It may be associated with postpartum psychosis because the mothers, can we move to next slide? Thank you. Because the mothers who may be suffering from postpartum psychosis, they want their child to not be with them, so they hurt their child, they abuse their child, and which leads to major injuries on mother to the child, which increases the hospital visits of the child, prolong their illness. So this syndrome can be associated with postpartum psychosis, in which the mother do not understand what is right for their baby, and they intentionally or unintentionally hurt their baby often. This is all from my side. Thank you. Any questions?
Thank you very much. Can we have some questions? Okay, since we do not have any questions for the speaker, so just
Thank you for all the time.
on my side, a very nice deliberation on the effect of maternal health, as well as why it is needed, why it is the need of R to protect and to look after the maternal health as well. I think
Dr. Mustafa Kirmani, he wants to ask something, but he's muted, I think. Dr. Mustafa Nadeem Kirwani. Sir, do you have a question? You can type in the chat box.
No, I just thank you. I was just typing that I may muted. I don't have any question. Thank you.
Okay, thank you so much, sir.
Sir, any expert feedback on the need of maternal health care?
I think it is very important, Dr. Sophia, that we
Yes,
need to have psychologists and clinical psychologists in gynecology thing, because we have in India at NIMHANS they have started a clinic, perinatal psychiatry, because they know that before the child is born, even mothers can have such negative experiences. Okay, and after the delivery of the child, even sometimes postpartum psychosis and postpartum depression can occur. So it is important to have a brief screening at least of the mother.
Yes, sir, you're right.
Yeah, that is very important actually.
But sir, in countries like India, where we are not able to fulfill the antenatal and the postnatal care, it is very difficult to arrange for such thing. And plus for the local population to get used to it. Now, many of the time the females do not come, that they are suffering from such kind of illnesses.
I know.
Yes.
At least we can try.
Yes, sir, we can try. That's a very good idea. Yes, sir.
Thank you.
Thank you, sir. Thank you.
Sir, just a simple addition to what you said, Kirmani said, that I think
Yes,
the
sir.
district mental health program is also aiming towards providing all these
Yeah, there
kind
is
of facilities.
There is a
because
national
of
mental
certain
health program which is at providing a psychologist at every district hospital in Uttar Pradesh for such
Okay,
kind of
okay.
psychological
Yes.
counseling. Yes, sir.
Yeah.
Okay. Thank you, sir. Okay, thank you for my side. Thank you very much.
Thank you very much.
Thank you, ma'am.
Thank you so much, Dr. Sophia, for such an informative presentation. We'll be now moving to our last speaker for the day, Dr. Mustafa Nadeem Kirmani. Dr. Mustafa Nadeem Kirmani currently is an associate professor in Amity Institute of Clinical Psychology, Amity University, Haryana. He has been the former head in the Department of Clinical Psychology, Faculty of Behavioral Sciences at SGTU, Gurgaon, Haryana. With a teaching and professional experience of around 10 years, Dr. Kirmani is a trained and licensed clinical psychologist from NIMHANS, Bangalore, and was awarded PhD in psychology from Aligarh Muslim University, Aligarh. He has published a total of 65 papers in different national and international journals of repute. With this, I would want to extend my warm welcome to Dr. Kirmani and would request him to take over the platform.
Yeah. Thank you, ma'am. Am I audible?
Yes, sir, you're audible, sir.
Okay. So first, I would like to thank IMHRC for providing me the opportunity to present my paper, and my special thanks to Mr. Sajid Kazmi for giving me this time. So what I'm going to do today, I will be very briefly discussing about the role of spirituality, how spirituality and mental health are related. Okay. So see, what is happening is a culture, I will be seeing many things from Indian perspective. Indian culture, if you see and observe, a lot of positive things people keep saying, okay? For example, if you say someone namaskar, if you say someone assalamu alaikum, many times they say, khush raho, okay? what it means is that the embedded culture of our country is that happiness is the highest value that people cherish. Okay, when people say "Khush raho," be happy, it means they are actually trying to communicate to us that try to be happy, and try to be happy is considered as one of the highest goals of our life. Okay, and in our day-to-day conversation, we find that many times people say भगवान ने ऐसा कर दिया, भगवान ने अच्छा कर दिया, Allah ने अच्छा कर दिया. Okay, so many of the religious and spiritual things are so strongly embedded in our culture, which I think as a psychologist, as a clinical psychologist, need to be explored and exploited so that those can be used and embedded in therapeutic interventions, because they are very, research has shown that spirituality and religious-based intervention, especially religiosity, which is coming out from intrinsic motivation, has a lot of positive mental health implications. Okay, and that is a base over which I will be discussing the role of spirituality in mental health. So let us see what is spirituality. Spirituality is a search for meaning and purpose in our life through inner journey, and which is mediated through relationships. What are those relationships? Relationship with each other, relationship with our nature, and our relationship with our Almighty. You may call it God, you may call it Paramatma, whatever you want to call it. Health, we, since deliberations has been going on since yesterday, so we all know that health as defined by WHO is very broader concept: physical health, social health. Now people have started talking about spiritual health. That is something is very, very important. Okay, now psychological health and well-being has happiness as one of the idealist goal, and the reverse of this is mental illness, which is, we may think as a profound crisis of personal meaning in life. And social health is being mediated with quality relationship, and which is in turn associated with well-being. Cultures that Indian culture is a highly collectivistic culture, which is strongly based on relationships, and we have a thing from coming up from Upanishad that whole world is considered as family. Okay, so it means there is strong emphasis is there that we are belonging to one family. We all human beings. So there is a desire, there is a motivation, intrinsic motivation from our culture that we need to connect with each other. Now, research has shown that those who are connected to each other, those who are having good relationship, their physical health and mental health is good. So this is something which we need to explore. Now, I'm coming back to spirituality. Spirituality, religion, and health. A lot of work has been done by Kenneth Pergevant. He wrote a book in 2013, Handbook of Psychology, Religion, and Spirituality. And a lot of empirical studies has been done on coping in the context of major stressors, natural disasters, chronic illnesses, burden of caring, divorces, and serious mental illnesses. And what they have found is, Pergevant work, that the conclusion they have found based on his work is that spirituality may serve as psychosocial sources of coping with stress. Spirituality is helpful in coping, especially when the resources are fewest or problems are uncontrollable. For example, let us take the example of what has happened in our country, in fact, the whole world. COVID-19 has come us to as a strong challenge, and I have found that many of the people are trying to cope this challenge through spiritual resources. Many times they were engaged in reading scriptures. Many times they were trying to connect with God. Many times they were reporting that they engage themselves in prayers, and in the process they say they feel better after they engage themselves with such spiritual based activities. Now let us see how these spiritual based activities effects on the brain. Very interesting study was done by Miller in 2013, and they found that those participants, those people who place a greater importance on religious and spiritual practices in their life, their cerebral cortices, the cerebral cortex, is a part of the brain layer sheet. They have thicker cerebral cortex, and they also found in their work that such people who put great importance on such activities, they are less prone to depression. So this is the outcome what Miller and others have found in 2013. Now, let us see what are the underlying mechanism, how engaging in spiritual activities, how engaging in prayer, what is the underlying mechanism? So Aldwin, ALDWIN, 2014, and he, in his paper, Psychology of Religion and Spirituality, 2014, they found that the effect of religiousness or religiosity in health are mediated through behaviors. Now, how religiousness is mediated? They say that it is mediated through behavior and self-regulation of health, whereas the effect of spirituality in health is mediated via emotional regulation on physiological processes. They have explained the underlying mechanism of this, how spirituality improves health, how spirituality improves mental health. It is through self-regulation skill and through behavioral regulation. And let us see what are the different spiritual religious-based interventions. One of the commonest spiritual-based religious interventions they talked about, research people are doing, is meditation, and meditation-based interventions. Meditation immerses the whole person in a psychophysiological experience, which is characterized by active passivity, that is, sitting quietly while inwardly alert and focused. They also say that meditation facilitates self-regulation and integration of physiological, emotional, cognitive, and behavioral aspect of human functioning. Now, how meditation changes the brain? How meditation changes brain and body? When compared to relaxation groups, the researchers have found that brain scans showed differences in only those who underwent meditation, especially mindfulness meditation. They also found that when they were engaged in mindfulness meditation, the more activity and increased gray matter density was seen in the portion of their brains that process stress-related reactions and areas related to focus and calm. They also found that lower levels seen in markers of unhealthy inflammation in their blood. And that the researcher who did this work was Creswell, and it was published in Biological Psychiatry 2016. Now, meditation is also considered as a part of yoga. Now, let us see what are the mental health benefits of yoga. Yoga reduces stress and anxiety. Yoga encourages positive thoughts and self-acceptance. Many research has shown that yoga sometimes enhances our memory and concentration, and it reduces the effect of traumatic experiences. And it is interdependence among it. It tries to connect our body, mind, and spirit. Now let us see prayer. Prayer is an inherently spiritual, religious activity, varies by purpose, formality, object, and subject of prayer. It can be general. Prayer can be specific, prayer can be for oneself, prayer can be for others, and prayer can be for all. Faith traditions, it may include, for example, mantra recitation, namaz, dua, ardas, and japa meditation. The existence of higher power as a potential explanation of healing. And many people explain that when we connect with higher powers, okay, that is considered as one of the potential explanation of healing. That people start perceiving that there is someone bigger than us who is there to help us as a supporting mechanism, And prayer also helps us to engage and converse with that almighty power. And you may give that name as God. You may give it that name as XYZ. Okay, it may be God, it may not be God. Through a regular prayer helps us to engage with, connect with, and submit before that power. And what is happening is through prayer we can be our own healer through a powerful prayer. And there are certain activities which has come from actually spiritual resources or religious resources. For example, service, as we call in Indian culture, seva bhav. Jan Seva. And research has shown that those people who are engaged in helping others, they are found to be more happy. So inculcating Jan Seva as a mechanism or as a behavioral activation, as a part of spirituality or religion, can have strong implications for improving the mental health of people in general, and even it helps in those who are having some mental health issues, especially depression and anxiety. The very essence of spirituality actually lies in serving humanity. And another important aspect of spirituality, is forgiveness. A lot of work has been done in this area, and forgiveness is also is a value which is being cherished in our culture, especially in collective cultures, and it is also practiced as in most of the faith traditions. The process of serving others improves, as I said, both societal and personal well-being. Meditation, prayer, and service. Meditation, prayer, and service share a complementary relationship, and together these practices cultivate positive emotions. It helps to undo negative, undoing the effects of negative emotions, and enhances physical, mental health, and well-being. And it also inculcates positive emotions. It broadens our attention, cognition, action, and it also helps us to build our resources, physical resources, intellectual resources, and social resources. And let us see what are the research problems, what are the spirituality and health related research issues that we found. One thing is spirituality is it is a very ambiguous term, and we still do not have a very universal definition of this. So it is very important that we need to define spirituality as in a universally defined way, which is still we are struggling to define. Second thing is we need to identifying underlying mechanisms, why and how aspect of spirituality and health relationship. Although some attempts have been done, as I discussed briefly, but still we need to find more and more mechanisms by which spirituality and health relationship are connected. Intervention based, there are intervention coming up slowly, prayer as one of the intervention, especially but still we need to find more empirical work. There is more empirical research need to be done in this area, which is although slowly happening, but we need to speed it further so that they become more empirical and more research based. Okay, and other things which research issues creep up when we talk about spirituality and health, they say it may have ethical concerns. Okay, sometimes they conflict with religious authority. Okay, sometimes they say that when we are using spirituality and religion as a source of intervention, it sometimes has the potential that clients or the therapist is imposing his or her religious or spiritual values on the client. So that judgmental thing might come up while we are using spiritual based research work in our clinical practice. So that also need to be taken care of. In concluding statement, I would like to say that spiritual striving practices introduce us to the positive side of life. The knowledge what makes human life most worth living. Spirituality also helps us to make our life most fulfilling, most enjoyable, and most productive. What we need to do is we need to explore, we need to exploit so strong cultural embedded statements in our culture, as I discussed in the beginning, that should become a part of our everyday practice and should be included in our psychological interventions. So that is what I wanted to communicate through this brief presentation. Thank you.
Thank you so much, sir, for such an elaborative presentation and giving us an insight into what is the role of spirituality and what about amalgamation of spirituality and mental health. So thank you so much, sir. I would request if anyone have any queries or they want to contribute anything, they can type it in the chat section and we'll address it.
Yeah, thank you. Yeah.
Dr. Faisal, just give us 1 minute. We'll give you the speaking rights.
Yes, Dr. Faisal.
Yeah, Assalamu alaikum, sir.
Walaikum salam. Yes, go ahead.
Very nice presentation. Since you talked about COVID, you talked about spirituality and religion. So there have been researchers which have suggested that religion is a psychosis. Okay, the spirituality is something that could be termed as an extension of religion. So I personally believe that yes, religion is something related to that, but since you're suggesting spirituality and religion have a role in mental health, so my curiosity, rather not just a question, my curiosity is that do this forced religion, like we're covering it with religious sheath, the mental health and entire psychological concept and psychological discipline, which is a scientific study of behavior. This does this force conversion of scientific discipline is essential, because in Eastern perspective, as the researchers have suggested, the Eastern perspective is what Indians are doing, what Indian psychologists and Indian professors have been doing in psychology. So there's this forced conversion of psychology as a discipline into a religious discipline, or connecting it with religion and spirituality is necessary. Is this necessary? Because mindfulness could be translated as meditation. Mindfulness is an independent concept. So meditation could be considered as mindfulness, using your brain, using your mental faculties. So that leaves less room for Buddhists, less room for Parsis, less room for Sikhs, less room for whatever communities and religious communities are like living in India or in Indian subcontinent. There have been like two approaches to psychology, and there have been two approaches to psychology in Eastern perspective, Hindu perspective, and the Muslim perspective. So why this is necessary to give it a religious color, to like a scientific discipline has been like repeatedly given a religious color? What is the need, like since it's a psychosis at the at the outset? Many people have suggested, many psychologists have suggested it's a psychosis. But why this forced conversion of a scientific discipline? Like why mixing all it up? Why not letting it be an independent discipline? That is my question.
Mm-hmm. Your question is over?
Yeah, I'm done.
Okay. So I think, Dr. Faisal, the thing is, we need to redefine science, number one. And if you see the history, scientists were, most of the scientists, in fact, were never against God. They always, most of them were talking about the positive aspect of religion. Okay. What has happened is religion versus science has never been a debate. It became a debate during the European era. Okay. What we have been observing, that religion, if you talk to people, what happened, how did you survive? Most of the people, they say they survive through some spiritual practice. When they say that when I offer namaz, I feel good. When I go to temple, I feel good. When I do jap, okay, I feel good. So it means there is something inherent in our psyche that we need to do something which connects us to higher powers, okay, which may not connect to higher power, but which has some spiritual value. So why, as a scientist, I think, why as a social scientist, I think I should not explore that area and do something very practical, which is embedded in the culture and used for the welfare of human being by mixing it together. Okay, not seeing religion versus science as animosity, rather as a complementary source of solace for people in general. So this is how I look at the things.
Okay, I am like I'm glad that you gave this perspective, but the last point, last is like Muslims have an approach to spirituality. They have an approach to religion. Okay, they feel good. They do spiritual practices. They engage themselves in spiritual things, and they feel good about it, right? They are psychologically benefited, as assumed by many of the psychologists. Okay, when they go to any other places of worship of other religious faiths and traditions, they feel uneasy. So are they feeling schizophrenic? Are they living dual lives? What happens to them? Because they aren't easy in the other traditions. They aren't easy. They are comfortable with their own traditions only, inclusive.
Yeah.
They aren't comfortable in gurudwaras. Many of them. I have been studying them. I have been working with them. They aren't comfortable in temples. So what happens to spirituality and psychology of religion then? Is it a secret life? Is it a dual life? Is it a split personality? What happens then? So that is my concern. Like, religion is actually like helping them or making them live a dual life, duality.
Okay.
That will be all, because I won't take much time. I have already taken much time. It's a topic of debate between many of the psychologists, including me and you. So thank you for explanation. But I believe personally there is a duality in that, in the behavior, because like considering Muslims and their behavior in their own spiritual settings and other spiritual settings.
See, my answer was not just for Muslims. Even if you go to temple, Gurdwara, and ask people in general, how do you feel after coming here? They say, I feel good. Okay. So regarding your duality thing, this is found in most of the things. However, if you talk about intrinsic sources of motivation, always has positive effect, and extrinsic sources of motivation always have created such type of issues, which is bothering for most of the people, So it depends how do you take religion, intrinsically motivated or extrinsically motivated. It's up to the person, actually.
Okay, then it could not be generalized then, sir. I believe.
No.
Yeah, it cannot be generalized. Yes, because so psychology of religion and psychology of spirituality stand questioned, right? Because when psychology began as a scientific discipline, we were getting a freedom from religious shackles. We were getting freedom from shaman practices. We were getting freedom from exorcism. We were getting freedom from many of those things which were unexplained. Like they were doing holes in the brain, skull, and believing that spirit or jinn would come out. So we were getting freedom from those practices as psychology became a discipline. Psychology became a science. And now in 2020 or 2010, let's assume, we are doing the same thing, because we are mixing religion, we are mixing that practice, we are mixing those practices again in the scientific discipline. So what is that temperament? Why that forced conversion of a scientific discipline? That is my concern as a whole. It's not just individual approach. Why this forced conversion has been done by a legal school, why this forced conversion has been done by Girishwar Mishra ji, why this forced conversion of a scientific discipline as a religious approach? This is my concern, because we have been getting freedom from these practices while psychology established itself as a scientific discipline. It got freedom from shaman practices, exorcism, these practices, that practice, and whatnot. So now we are mixing those things again. So why this all is happening? This concerns me as a scientist, as a psychologist, whatever. So there's no answer to that, basically. There's no answer.
You will find answers. You'll find answers if you read the books by established founders of psychology. I suggest you to read the book by William James, how he explains the role of spirituality and religion for mental health. Read the book, Varieties of Religious Experiences.
But sir, you will accept that spirituality is being researched as present, so we must not be judgmental about spirituality, that spirituality does that. It is
based on research. Based on research. Our findings are based on research, not our experiences or not what people say. It is based on research.
Okay, sir, I'll take that. But this is concerning. The forced conversion of a scientific discipline is concerning.
And you should know, Dr. Faisal, even APA, we have Division 36 is talking about religion and spirituality, you know, because people are finding some benefits. So why can't we explore that area which might be beneficial for human beings without forcing a conversion, you know, that, as you said, there's no need for forcing exploration for human benefit. Something that can be benefited for human beings is an area that needs exploration, right?
Yeah, it needs exploration, but why the comfort? Why something is comforting a Muslim or a Hindu should be forced on a Parsi or a Sikh?
That should not be forced. Yeah.
Yeah, but when the spirituality and religiosity is mixed with a scientific discipline, it is actually apparently forced. Like if Islamic or Hindu practice, for example, gives like relief to somebody, so that is being forced on a Parsi or a Sikh. My curiosity, my concern is there. That is my concern. Like there should be no religion in scientific discipline, no spirituality in scientific discipline. There should be.
But for that, we need to redefine science, right?
Yeah, we have been defining that since.
No, redefine. We need to redefine science.
We have established science, sir. So, but there is no answer. There is no clear answer to that, and that is like very cloudy thing. Individual experiences are like generalized for I don't know whose benefits.
No. One day I want to make it one thing clear. It was individual experiences of the patients which Freud saw, 188 patients, based on their individual experiences, traumatic experiences, he formulated a theory, number one. Number two, Piaget did a study on individual interview of children. Based on their answers, based on their interviews, he formulated a cognitive development theory. This is how science develops, Dr. Faisal.
Yeah, another scientist, Robert M. Pirsig, has observed that when a person suffers from delusion, we call it insanity. And when many people suffer from delusion, we call it religion. That is also from a scientist.
That I do not know.
Yes, I'm quoting scientists.
Yeah,
but
yeah.
that is an APA manual. Yes, that is in DSM. No problem. I'm okay with the aspirations and researches by the Aligarh school. I'm okay with that.
No, it's not about a Aligarh school.
Yeah.
It's about the division 36 of APA. Please go and read that division work, Parjament's work.
I quoted Robert Pirsig from the APA only, sir. But
don't quote Aligarh school. Please don't quote Aligarh school. You have to talk a scientific thing, okay?
Yeah, those approaches came from Aligarh school because the spirituality, the Islamic spirituality, Islamic psychology, the forced conversion has been coming from there only.
I do not know. I have never quoted Aligarh, one of the things, you know. It's your thing.
It's not my thing, but I have seen researchers coming from there.
So you may talk to researchers there.
No, it's not about individualizing. Like you people, not just Aligarh school, but there have been spiritual researchers. My concern is there only religious and spiritual sheath for a scientific discipline. We got liberated from that, and now we are trying to cover ourselves as psychologists with religion and spirituality. My concern is there.
Gentle and polite reminder.
I'm not limiting myself to a legal
so we can.
There's no answer basically. There's no answer.
More on
there
the
is a
scientific deliberations, and
scientific
we can have the discussions later on. Thank you very much.
Thank you, Sajid Kazmi.
Thanks.
Thank you so much, Dr. Kirmani, for
Thank you,
for the presentation and such an elaborative clarification of the raised concerns. And thank you so much, Dr. Faisal, for giving us such a food for thought. Thank you to all the thank you to all the eminent speakers present here and all the DA participants who have been very patiently listening and have been actively participating throughout the sessions. I hope you all like the sessions. With this, we will come to the end of our first part of the conference. Since we are already running a little short of time, we will take a quick break of 10 minutes, and I will request you all to join back by 2 p.m. so that we can start with the technical sessions. Thank you.
Sure.